My name is Valerie Nicholson. I want to thank you for coming to our seminar. Options for paying for care. I think you'll find it very beneficial. It won't be like that UT game last night. I'm sorry. It's going to be better. This is put on by our Parish Health Ministry and Stevens Ministry. And on your table are brochures about both of those ministries. Your table's loaded. It's got paper and pencils for you to use. It's got books about senior care if you need it. Do just kind of filter through it and take what you need. This seminar will be recorded and it will be posted on the Parish Health Ministry website, which is under Church Street's big website, which happens to be Church Street UMC.org. Kelsey said it'll probably take about a week. She hopes to get it up this week, so it will be available. I would like to say a big thank you to our church staff, our custodians who helped us get all set up, and to Kelsey Glenwater, who is our Director of Communications. She got the registration process, she did our programs and our flyers. I'm also really grateful for our seminar planning committee, of course our Gabe Blake, who gets our wonderful speakers and our panelists, to Julie Thornburg, who helps arrange our volunteers for registration and greeters, and she gets our lovely door prizes. Yes, you get a prize if you have the right ticket. Now, did anyone not get a meal? Because we might have some extra ones, seriously, so don't go hungry. Okay, there's ham left, vegetarian. I think the turkey's gone, okay? But do get you a meal, don't go hungry. Lastly, this is the most important. You have these pretty colored cards on your table. And we love your feedback. We like to know how we can improve and what topics you might want in the near future. So please do fill them out and give us your feedback. Thank you for coming, and now we'll turn it over to our MC, Ms. Megan Dunaway.
Good afternoon, everybody. It's so good to see you all here today. Thank you for coming out. I know these seminars are extremely important, educational, and we are going to continue doing these for all of you. And again, love the suggestions, so please do fill that out. Just a couple housekeeping items, of course. So restrooms, if you need to go, please feel free to go at any time. There are restrooms behind you around the Welcome Center. There are also restrooms up here, up these stairs, just a little bit further, so either of those, please feel free to use. Also, there is a resource table. Erin is sitting at the resource table right now, so yes, thank you, Erin. Thank you. So please go check out the information there as well. Again, if you haven't gotten lunch, please feel free to go get one. And we are going to have Ms. Pat Clendenin, Reverend Pat Clendenin is over here to come and bless our food for us.
Thanks, Megan. Let us pray. Creative and creating God, we are reminded of your faithfulness once again with the changing of the seasons. And even as we were almost blown into this place, we felt the winds of the Spirit in the reception and the presence of each other as we came together. And we pray that we will continue to know Christ's presence at the center of each table as we fellowship together. We thank you for the months of preparation and all who have worked so hard to make this possible. We know that the information being shared today is so important, and we thank you that we have this opportunity through Church Street United Methodists. And so be present with all of us during this time, and may all that we do and all that we say be to the honor and glory of your name. In Christ's name we pray. Amen.
Hello, everyone. I am Gabrielle Blake. I'm a licensed clinical social worker and a member of this church, and so happy that each of you joined us here today. This topic was brought up by our friend Jeff, who's actually in the background. He got up at last year's conference and he said, well, what about the elephant in the room? You guys are telling us that we need this care. How do we actually pay for the care? So what we hope you will do is leave here today with a general information about tools and resources available to help you no matter what kind of care you might need. I'm going to introduce my friend Glen Kyle in just a minute, who's going to talk to us about VA and choices. Then we're going to have a break, and after that time, we're going to have a panel discussion, as you can see here set up, with more information about other programs and an opportunity for you to ask questions. So if you think of any today, jot those down in your notes, and of course, you'll have an opportunity to also ask questions of Glen. If you need contact hours for your license, some of us are social workers or in the helping profession, I have those in the back over by Erin, who is our AV person. Thank you very much, Erin Blake, for doing that. Glen Kyle is a certified elder law attorney by the National Elder Law Foundation. He is the owner of the Knoxville Law Office of Franklin and Kyle Elder Law, which is where I also happen to work. And we have won the Knox Star's Best Law Firm for 6 years in a row. Thank you very much. He focuses his practice in the specialized field of elder care law, which includes life care planning, Medicaid planning and advocacy, estate planning, special needs trust, and probate and trust administration. Glen graduated with honors from the University of Memphis Cecil C. Humphreys School of Law, where he worked in the Elder Law Clinic and served as the business editor of the Memphis Law Review. A Murfreesboro native, Glen earned a bachelor's degree in history from Rutgers University. Before attending law school, he pursued a decade-long career in banking at the branch level. This experience motivated him to pursue a law degree expressly for the purpose of advocating for older adults. And I'm going to raise this podium if I can get my AV person to come help me, because Glen is just a slightly bit taller than I am, just a little bit. I don't know how to. All right. Welcome, Glen Kyle.
Hey, I'm good. I think I know you. When I got hired, I was the first male that was hired. It was the elder law practice of Monica Franklin. They never hired a male. They always called themselves the founding mothers instead of the firm. And so when I got there, though, everybody was 5'2", except for one employee, Gwen, who's still with us because it's like taller, and then I was 6'4". So everything that we had to do when we stood up was always kind of like set up for Monica level. I started out right on the board, like underhanded. It just didn't work so well. But thank y'all for having me. This is a beautiful church. I was raised in the Methodist Church in Murfreesboro, First Methodist, but I've always really wanted to be inside of here. I mean, it's such a landmark in Knoxville, and we've had such wonderful time. We had a client that was from this congregation. It's just an amazing group of people. So thank y'all for having me. Thank you, of course, to Gabe. My name's on the front, but I joke that's only because it's a law firm. So I've had the absolute pleasure to work with her. I think everybody knows that she's a force of nature and a real asset, force of good in the community. So thank you all. The topic today is we're going to talk about paying for care. So not going to be a huge surprise to anybody, but caregiving has gotten quite expensive. And as we age or we have certain conditions, I usually say that, all of us, if we live old enough, are going to get to the point where we need help, right? It's just kind of part of being human. And so just to give you an idea, the different levels of care. So the first one is getting somebody to come into the home if you're needing it. And usually when we're talking about here, we're talking about people need help with what we call the activities of daily living. So that's your bathing, dressing, walking, toileting, and transferring, the ability to get out of like say a bed to a wheelchair or vice versa. Before that, you can need help with like cooking and cleaning and yard work and things like that. The good thing is, all of that's kind of cheaper, right? Getting a maid service or getting somebody to help with the yard. But when we're needing help with the hands-on care, the first thing you can do is get somebody to come into the home. You can either get somebody through an agency or a private, private individual. If you get a private individual, we've seen a lot of charge between $15 and $25 an hour. Agencies are probably $30 to $34 an hour in our area. They're usually going to want a 4-hour minimum, right? This is really good if I've got a couple that are living together and one of them's a primary caregiver for the other. Well, nobody can be a 24/7 caregiver, right? I mean, it always amazes me that if I'm going to be a caregiver for my spouse, people can expect me to work 24/7. But if I'm going to work for your spouse, now I get to work 40 hours a week. I get evenings off. I get weekends off. I get overtime, vacations, right? Same job. So what we put on the family can be really challenging. A lot of times getting caregivers to be able to get out of that, to give that caregiver a break are really, really important. Gabe will usually say that you can't pour from an empty glass, right? So being able to get that break where that person can shop and go to church and have hobbies and have other things to get a break and help them be a caregiver longer. With that being said, it's hourly, so if I'm only getting help for a couple of days a week, that's pretty affordable. If you really get to the point where you're paying 24/7 in-home care, that can be $20,000 or more a month, right? So a lot of people are in a position to pay for that, but most people aren't, at least long term. Past that, there are independent living facilities. We didn't write it on here because they don't actually give care, but they can be great first steps. That's a place that you move that'll help you with, a lot of times they'll take care of the cooking and the cleaning for you, but they're not really going to help you with the bathing, the dressing, the walking, the toileting. They can be anywhere from $2,500 to almost $6,000 a month. Beyond that, it's much more common as assisted living. So again, it's like moving into a hotel or a dorm to some extent. You've got your own room. It can be anywhere from one room or a studio up to 2 bedrooms generally. They'll also do the cooking and the cleaning, but they'll help you with those activities of daily living. A lot of times they have a lot of activities on campus and off campus. They're really wonderful in a lot of ways. Of course, I don't like cooking and cleaning, so they sound really great to me. And so, again, they're going to start probably about $3,500 a month. They'll go up to $6,000 plus. Comes down to how many rooms you get, the level of care you need. The more care you need, the more they charge. And then just how swanky the place is, right? There are some of them that are pretty plain Jane, and there's other ones that are like moving into a cruise ship with like chandeliers and bellhops and wine bars and all the rest, right? Those look really great, but trying to find one that's got a culture that kind of fits you can be important, and it's important they're all there. The next step above that is memory care. And sometimes I'll call that assisted living plus, right? If I'm in assisted living, on average, they're going to be able to help you about every 2 hours. Some people need more care than that, right? And then a lot of people that have, say, dementia, I had an uncle who was very active. Like he played semi-professional tennis, and then he was still playing competitive tennis in his 80s, right? He played with the men, then he played with the women, then he was playing with the kids. And he got frontal temporal dementia, so he would wander and couldn't find his way back. And honestly, a couple of caregivers they got for him could not keep up. He would just be booking it, right? And so memory care, you have to have a code to be able to get out of the building, right? On average, that's going to be about an extra $1,000 a month. They're usually in a different facility or different wing of the regular assisted living. And then above that, you've got nursing facilities. This is the level of care that this is an actual medical facility, assisted livings and memory care are really residential facilities. This is where a lot of people don't want to be, but if you need this level of care, you need it, right? Most of the places are in shared rooms, but they have nurses, a lot of times you can need an ostomy bag or things like that need to be there. But by far the most common reason our clients end up in a nursing facility is if they get to the point they can't transfer, you can't stand up, right? On all of this, the amount of level of care, the care you need just really increases if you can't get from a bed into a wheelchair, right? For an assisted living, you've got to be able to get out in 13 minutes if there's a fire, right? And so if you're able to get to a wheelchair and they can come and get you out real fast, that you're going to meet that criteria. If you can't, sometimes they'll have the staffing to do that, but that's a lot of times where our right line rule is. So the short story I just always want to say on this is that none of this is cheap, right? A lot of people think that in-home care is the cheapest way to go, and it is at the beginning. But when you get to needing a whole lot of care, it's the most expensive. A lot of people think it's only that or nursing home, but there are wonderful assisted living and memory care options in the middle that are usually the most affordable for the care you get, which is one of the reasons why there are so many of them being built. And then the last thing is the fastest way to go from being at home and living independently to needing a nursing home is really a bad fall. So you really need to be careful at the house with watching for throw rugs and exposed cords. Anything that can mitigate your fall risk is really it's an important investment before you need it, right? All right. So we have a Medicare expert here, so I'm not going to go into this much, but I will say the first thing that everybody thinks about is, hey, I need care and I have Medicare and it pays for my health insurance, And it is your health insurance and it can be wonderful, right? It's going to pay for doctors and hospitals and drugs and lab tests and things like that. But when it comes to actually getting hands-on care, not so much, right? Now, if I fall and I say break a hip or I have a stroke and I need to get skilled rehab, you can get up to 100 days of that. If you need occupational therapy, physical therapy, or speech therapy, we'll call that home health. They can come to you, but that's usually a couple hours, 2 to 3 hours a week, right? And you can get that at home or assisted living or nursing home, but you've got to pay for the assisted living or the nursing home, right? And then finally, hospice. Hospice is a wonderful program. We have Stephen Ministers here, so that's I don't need to tell you all much about that. But it's a wonderful program. It is paid by Medicare, which is wonderful. But if you get hospice, generally in a nursing facility or assisted living, you're again paying for the actual community or the facility costs, right? So, what resources do we have to pay for it? Well, the first thing is your income and your Social Security. We also have your assets, your savings, your investments, retirement accounts, family, which in some ways and a lot of times is the most important one, right? I can have 2 clients with almost the exact same asset structure, but one has a wonderful child nearby, and the other one, the nearest child, is in Oregon. I say that because my sister moved to Oregon just as my wife turned, and my mom turned 80, and my wife is not quite forgiving her for you, but that's a really important one. Home equity is something we can look at. Of course, long-term care insurance is a wonderful thing to have if you don't pay for this. Most of us don't, but it can make a real big difference. And then we've got VA, EDIO, CPA, that's for energy workers, work usually a bridge around here. And then we've got Medicaid. So today we're really going to focus on VA. I'm going to focus on Medicaid and VA, but when we have the panel later, we'll have people that can speak to all of those. All right, so the VA is in some ways one of the most convoluted things in the entire government. I don't think anything else has mortgages and college education and healthcare. And so over the years, we've added a whole bunch of different laws. They're all give a lot of wonderful support, but they all have different criteria. They don't even agree on what an eligible veteran is, right? And sometimes we have more funding to fund all of them than others. The biggest one we talk about a lot of times is service-related, service-connected disability, and that's when you're hurt while you're serving, right? And so at that point, they're gonna be able to. And it doesn't have to be. You don't have to know about the injury immediately while you're serving. It can like surface many years later, but you still have to connect the disability to the period you're serving. And then they're going to figure out the percentage that you are disabled based on that, usually between 0 and 100%. Yes, you can be disabled 0%. It's interesting, but it's VA math. I will tell you, I've had people try to tell me how you go from, if you have two 20% and you add them together, you only end up at 30. I will tell you the math on this is the craziest thing I've seen in a long time. I am not going to regale you with it because I don't understand it completely, but that's where you talk to talk to the VA. But if you are on there and you give a certain percentage, they will pay you a certain amount per month based on that disability, right? My brother's a retired test pilot. When he was going through flight school, they did like a parachute drop. He cannot pick his left arm up above here and hasn't been able to for 30 years. They rated that 0. They did a x-ray on his knee and decided that he's 40% disabled on his knee. He has no problem with the knee, has never felt the knee. I mean, he did not know there was an issue with the knee. He did not know why they were even taking that particular x-ray. And so there's a certain amount of that that's there. But the good thing is you get that amount there, and it can be increased later, right? The big thing a lot of times we see, especially for like Vietnam veterans, which my dad was the one. A lot of times, Parkinson's shows up much later in life. But if you're boots on the ground in Vietnam, that's going to be enough to get the 100% there, right? DIC is the other one. So generally speaking, if I'm this is going to be for the veteran themselves, not the spouse or the child. The exception is if the veteran dies and the death is because of the service-related injury. It's not enough just to be service-related, even 100%. You have to die from that. But if you do that, there can be a monthly payment that's paid to the spouse or to the minor child, or sometimes a parent they relied on them based on that, and that's called DIC there. So the next thing is, there are VA clinics, there are VA hospitals, there are VA nursing homes that are established. I'll call it informally VA direct care. That's when you can actually show up and get drugs or get actual VA doctors. They're going to cover any illness or injury that's connected to the military service itself, right? We added the PACT Act, I guess, 3-4 years ago. Now, if you had exposure to a toxic substance, that's also going to be covered, right? Anything related to that. Every other veteran basically gets put into a different priority group, and they don't always have enough money for all the priority groups, right? And so in order to be in a lower priority group, the higher service-related disability you are, the higher you are there. If you were, like we said, like boots on the ground, Vietnam, exposed to Agent Orange, that's going to put you up to the top. Otherwise, they're going to look at, whether you were a prisoner of war, had Purple Heart, Congressional Medal of Honor. I've never met anybody with one, but you've got anybody, they're hired. And they can look at your income on that one as well. So that kind of does that. Let's see. The other, now with the PACT Act 2, if you were boots on the ground in Vietnam, or I have it here, the Gulf War, or in one of the wars after 9/11, boots on the ground, you're also on the priority list, right? Historically, before that, just serving boots on the ground was not enough to get you actual direct VA care, right? You had to have the service-related disability or have the low income. Now those veterans do qualify, but they're in a very high priority group, just so you know. Okay. there's one thing I was looking for in here that I'm not seeing. Here we go. All right, I'm just gonna switch over to here. That wasn't it. Never mind, I had that and I took it out, so I'm gonna quit looking for things that don't exist in here. I'm sure that's not confusing at all. Hopefully there was no, the thing I was looking at is that if you're at 60% service-related disability, you get, included nursing facility care is what I was looking for on that. And if you're at, I think 50%, then if you're 50% service-related disability, you get coverage for all your healthcare needs, not just the ones that are service-related. I'm going to double check on that number. That's what I was looking for on there. That's what that comes down to. All right. So the other program is the VA pension, and this is for non-service-related disability, right? All the rest of it, you can go down to the VA clinic at Ray Mears or go to your local officer to kind of help you with that. This you can too, but this is for people that have a level of disability, but it's not tied to when they were served, So you can't have both of these, you only get the higher of the two. And you can imagine that generally speaking, the service-related is higher, but not if you only have like 10% for hearing loss because you were in artillery or something like that, right? Now, because it's non-service related, you've got to also qualify medically and financially, right? Bill Gates, if he had served, if got hurt within the service, they're going to help him, right? This one, there's going to be an income and a financial qualification. So the other thing is, this isn't for all veterans. You have to be a wartime veteran, which means you had to have, if you're before 1980, you had to have 90 days active service, one of which was during the wartime, right? And you have to have other than dishonorable discharge. If you're entered service after September 7th, 1980, you have to have 2 years of active service. So if you ever wondered what the VA thinks an active wartime is, this is it. And they are not what you would necessarily think. World War II ends in 46, where I was a history major, and I can tell you the war actually ended in 45. But we had troops that were there in the occupation, for Japan, for Germany. They're going to count that period. So always double check the dates, right? They're not what you would always think. Vietnam's interesting because it has a longer period for people that were actually boots on the ground, and then a shorter period for all veterans, right? If you were active during that date, it does not matter if you were hanging out at Key West or if you were at, if you were boots on the ground in Vietnam. It's only whether you served during that period, right? So that's an important one. And so those are there. So the other thing that makes this program a little bit complicated is there's multiple levels of it and it pays different amounts, right? The first one is kind of based on your level of disability. There's kind of the basic pension, what we call disabled. There's a next level up that's based on whether you're homebound, and that's kind of what it sounds like. You can't leave the house, right? And then the highest level is going to be the aid and attendance. And you're going to need more care. We'll talk about that in a second. And then they pay the amount based on whether the veteran is single, they're married, or have one dependent, right? But the surviving spouse, even if they weren't a veteran, can actually get benefits under this. And then the highest level that you can get is actually a veteran married to a veteran. Boy, that did not come out right. If you've got two veterans that are married together, they get more money, right? So you can see the amounts there. The cool thing about this is they're going to pay you this money and you can use it for care pretty much wherever you want to. So you can use this for in-home caregiving, you can use this at pretty much any assisted living, you can pay it at any nursing facility. This is going to be considerably different than we talk about Medicaid. So we really like this to help pay for care in a lot of places that aren't going to, be in the Medicaid program. So in order to qualify, we're going to have an income, an asset, and a medical test, right? The medical criteria is going to be for the highest level for aid and attendance. The common ones, do you need the aid and attendance of another person? So if you need help with 2 activities of daily living, bathing, dressing, eating, toileting, that's kind of the fastest way to do it. I'll tell you, they're going to also grade this a lot more lax than Medicaid's going to, right? And so a lot of times we need a doctor and to say that you need that level of care, and then something from the caregiver saying that they're providing it. There's also another one if you're in the nursing facility. If you do have reduced capacity such you need 24/7 oversight, that can qualify here too. But you need that level of care. The second thing is we have to look at your income. Now, I said earlier, the lowest level of this pension you can qualify for without needing the help of other people if you're considered disabled if you're 65, but your income has to be really, 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 really low, right? But for a lot of our clients, you can qualify even with Social Security or even with a pension, because what they'll do is they take your income for VA purposes is your annual income of both spouses, and then you subtract out your qualified medical expenses, which is what you're paying for long-term care, plus what you're paying for your Medicare premiums. They don't count drugs, right? If that amount equals 0, you get the full benefit. Now, the math here is a lot more complicated than that, but that's the shorthand. If it doesn't get all of your income off, you can still qualify for part of that pension, but maybe not the whole amount, right? They'll reduce it by the amount of income that you still have. But the short story is always going to be, if you're paying for as much in income as you make per month, you can get the highest benefit at that level, right? That's how we're going to have this conversation and not spend the whole rest of the hour just talking about income for VA purposes, right? So we got a question of what unreimbursed medical expenses are, and they're here. So that isn't the, I'll do this. Yeah. Okay, wait, there's one more thing there. All right. Income's only part of the actual calculation, though. There's also a net worth component as well, right? So what they're going to do is they're not going to count your house. They're not going to count one car. They're not going to count prepaid funeral and burial. They're not going to count a house and property up to 2 acres is the actual rule, right? If you have an amount over 2 acres, they're going to count that. The rest of your assets they're going to add together, and they will add that plus any positive income you have above that 0. And if the amount is under, right at 160,000 this year, you qualify. If the amount's over that, you don't, right? They're going to count all the assets of both spouses. It doesn't matter which one owns it. They're both going to be relevant on that, right? And so the short story is you got right at 160,000 and less plus the home, you're going to qualify, and you're spending enough on care to offset your income. If I'm spending $9,000 a month in the nursing home and I only make $4,000 in income, though, they're not going to take the rest of that $5,000 and annualize it and subtract it against my net worth. It can't go below 0. So I know, but that's where we are. So short story is, if you need help with 2 activities of daily living or need cognitive decline, so you need 24/7 oversight, plus you're spending as much on care as you make per month, plus they don't count a house and your other assets are 160,000 or less, you qualify. And you can pay up to $2,800 a month for a married veteran, $2,300 a month for a single veteran, or $1,500 a month for a surviving spouse. That's the short story. The good thing is you can use it pretty much anywhere. You don't have to be as disabled as you have to be for Medicaid. And there's no estate recovery. They don't come back after your things after you die, right? So all of those are really good. The bad thing is it can take a long time to get an application through VA, right? And then the other thing is, before October 18th, 2018, there was no penalty for gifts. So you could say, I'm at 250,000, I need to get down to 150,000, I'll just give that to the kids. Well, you can imagine there was some abuse there. We had people with $5 billion trying to do that. And so they added in a penalty period. So when you apply, they're gonna look back 3 years from the application day, figure out the amount that you gave away, right? And then based on the amount of gifts you made, they're gonna not help you for a certain period of time. So basically for every $2,800 that you gave away, they won't help you for 1 month after they actually would, right? So we have to be really careful with those gifts. They don't care if you're spending your money on you, they don't care if you're spending it on your spouse, but if you're giving it to the kids, that's where we have issues, right? Or other family members. The VA is only 3 years, where we'll talk about Medicaid in a second, it's gonna be 5, which is kind of nice. But the penalty actually does go out for 5. So you have to be really careful. If I made an impermissible gift 2.5 years ago and I apply now, and it was a big enough gift, they still won't help me until it's been 5 years. Where if I just waited and applied 37 months afterwards, I would qualify then. You see what I'm saying? So the penalty, if you make the gift and you apply during that period, the penalty can actually go longer than the actual look back period. So it's a real trap there. The second thing is they don't penalize all gifts, unlike Medicaid. They're only going to penalize the gifts that actually accelerate your qualification. So if I'm at 180,000 and gave away 80,000, they're only going to penalize me for the 20,000 that sped me up getting onto the program. They're not going to penalize me for the next 60 because I would have qualified at 160 either way, right? And then, and you get an interesting thing there too. If a house doesn't count and you give it away before you apply, that doesn't count against you. But if you sell the house and then you have cash and you give that away, it does count against you. I'm not saying all these make sense. I'm just telling you the way they are, right? But that gives us some planning options there. The short story is, when people see these, a lot of times they're like, the first thing they want to say is, hey kids, here's my stuff. And there's penalties there, and that's dangerous in a lot of other reasons. So we'll talk about that in a second. But that's not my first thing to do. All right. So VA, just as a nice bow on there, wonderful benefit. If you got hurt while you were in service or you had certain types of service, you can get direct care, right? Otherwise, there is a wonderful program called Aid and Attendance, but there's an income, an asset, and a medical test for it, right? And then there can be a penalty for gifts. All right. So if you weren't serving or your spouse wasn't serving, or even if you need a lot of care and you were a veteran, aid and attendance is wonderful, but if I'm in a nursing home that costs $10,000 a month, for a lot of us, $2,400 is nice, but it isn't going to be enough to pay for it, right? So that's where Medicaid comes in. So people get Medicare and Medicaid confused. The short way to do it, Medicare ends with care, that's your health care, right? Medicaid ends with aid. This is for people that have needs. You've earned your Medicare working through basically your premiums, right? Medicaid, you got to qualify for, which means you're going to have to be some level of poor and sick, at least in Tennessee, right? So Medicaid's a lot more complicated, which is exactly what you want to hear from me say when I said after what we've been through so far. The other thing that gets Medicaid more complicated is Medicare is all a federal program, right? Medicaid is actually a federal and state partnership. So the federal government comes up with a lot of rules. They fund it 50 to 70% or 66% of the amount per state, but the states run it. The states have their own rules, they have their own programs. And so if you're looking this up online or using ChatGPT, be really careful, because if you're getting the rules from Florida, they may or may not be the same from here. And if you're getting the rules from California, they're not. Stop looking. It's not worth your time, right? Completely different. So in Tennessee, we call it TennCare. So if you ever wondered what the difference is, Medicaid's federal, TennCare's state. All right. The other thing that makes this really confusing is that TennCare's got a good 7, 8 different programs that all serve different populations. They all have different rules. They all have different benefits. Like almost half the kids in Tennessee get their health care through TennCare, right? But that's a completely different rules. That's a completely different benefit. The one that's for long-term care only is called Choices, right? So Medicaid's federal, TennCare state, Choices is going to be for long-term care. And you can figure with a name like Choices, we're going to have some options or some choices, if you will. All right, at least 2 people laughed. I'll take it. Gabe knows I'm a newish dad, so my dad jokes are still working on it. So under Choices, there's 3 groups. The first one's Group 1. This is the one that's been around the longest. I think the one that people know the most about, the one that's the most similar between states. This is for nursing facility care only. So if you go to a nursing facility that takes it, and most do. I think there's 4 or 5 in the East Tennessee, well, in the Knoxville area that don't. Then basically it's going to help you pay for the cost of the nursing facility care. Once you're on, if you're single, you basically contribute your income as your part of the bill. You're allowed to keep $70 a month to pay for your Medicare premiums, and but you're allowed to keep enough to pay for your Medicare premiums plus a full $70 a month for everything else you need, like usually your clothes, haircuts, and toiletries. But for that, they're going to pay for the rest of the full cost of the nursing facility, right? They'll also pay for any copays and deductibles that your Medicare doesn't pick up for. They'll pay for the pens and things like that. So, you know, if I'm making $2,000 a month, this benefit can be worth $9,000, $10,000 a month, right? So that's why I was trying to say, even with a full aid and attendance benefit, a lot of times that's not going to get us near as much as the choices. So we don't want to do anything for that benefit that's going to make us lose this one, because this one just is worth a lot more, right? If you're married, they're not going to take all of your income, because they want to make sure that the well spouse can still, eat, right? So what they're going to do is the spouse in the community gets to keep all of their income, regardless of how much it is, right? They can make $10,000 a month, they get to keep it. The spouse in the facility, though, that we're qualifying for, they have to contribute their income. Now, for low-income individuals, they want to make sure the well spouse is still able to eat. So there is a minimum that they have to get, about $2,400 a month, right? So if I had a spouse that only makes $900 a month, the spouse in the facility wouldn't contribute all their income. They get to give a little bit over, right, to a base level of $2,400. But the short story on that is you contribute your income, they pay for the rest of the care costs. Now, Group 2 is for people that would qualify for nursing facility level of care, but we can meet their needs in the community. So we'll call this home and community-based services. This will provide in-home caregiving, usually about 35 to 40 hours a week, right? Now you're on the hook for the rest of the week, but that can be a real big benefit. Or if you go to some assisted livings, and it's a pretty short list, right? This isn't like nursing facility where most take it. This is like most don't, right? If you qualify on there, then you can have to contribute at least $2,200 a month, but they'll pay for the rest of it. They pay basically $1,400 a month toward the cost of the assisted living, but the rule is written where if you contribute $2,200 a month, they're not supposed to charge you anymore. You notice I said the rule is written as. I'm not gonna say that's exactly how it works in practice, but at least you get them to pay $1,400 a month for it. So, short story on this one, there's a benefit in the nursing home, there's a benefit at home, there's a benefit at the assisted living. You know, in all of them, the well spouse basically gets to keep their income. The spouse in the facility and the nursing home has to contribute all their income other than $90. In the assisted living, you've got to pay at least $2,200 a month. And at home, you usually get to keep your income because you've got to keep the lights on and keep yourself fed, right? But all of them have a benefit at the different levels. All right. How do you qualify? We're going to have 3 tests. They're going to be income, medical, and assets, kind of like VA, but all the tests are going to be different than VA. All right. The first one's going to look at the income test. So they're going to look at your gross income before anything's taken out for taxes or Medicare. And if that amount is less than $2,901 a month this year, then you qualify, right? We have an or up there because when you think about it, this rule makes no sense, right? If I'm in a nursing home that costs $10,000 a month and I worked at TVA for 30 years and I have a wonderful pension and I'm making $6,000 a month, but I've been there for 10 years and I'm out of money, it doesn't matter if I make $6,000 a month or $600 a month, I still can't write a check for 10, right? So we have to have a workaround. And so that workaround is called a qualified income trust. Some people call it a Miller trust. It's a separate trust that we set up where somebody else has to be in charge of the money. Your excess income goes into it every month. And we use that to contribute to your part of the bill toward the nursing facility. As long as we do that, you qualify, right? The catch is when you die, whatever's left in here has to go to the state to pay them back for what they paid. But there really should be only money in here for a few days a month. You just put it in, you take it back out, right? I'm mentioning this for 3 big reasons. The first one is nobody understands this. Actually, all 3 reasons are nobody understands this, right? So a lot of the other types of Medicaid are really set up on a straight up income test. If the one for children, if you're $1 above it, you're out. If you're $1 below it, you're in, right? That's kind of how most Medicaid works. So a lot of people think that this one works the same way, and it doesn't for the reason we were talking about, right? So if somebody tells you you're above 2901, so you'll never ever qualify for this, don't listen to them, okay? The second reason why I want to mention this is because people don't understand that trust. So they think you can set it up and put all your assets, what you own into it, and qualify tomorrow. That doesn't work either, right? Because this is just for high income. And you don't want to pay them back with everything when you die anyway, right? So that's the second reason. The third reason is this isn't something you really need to set up until you get to the point where you need care. So I wouldn't be running, this isn't something like, hey, I need this today. I just wanted to let you know that it's out there, right? There is an income test. We can get almost anybody to pass it, is what it comes down to. It is a way that they can turn people down until they can see an attorney or has to be drafted trust, which is kind of unfair, but that's the way that one works. All right. The other thing is, I think I said this, but they're only looking at the income of the spouse who's in the facility. They're not looking at the well spouse's income for that calculation. Right? All right. Well, you have 90 days. You have 90 days by law from the time of the application for them to make a determination. At that point, you can put it into anytime that they come out and say no, which could be sooner than that, but I'd guess 90 days. Then you can file for a fair hearing. They then have to set it within 90 days unless you or both sides agree to put it forward.
So what if you do pay for household expenses in that time?
Good question. So first of all, I'm taking off the jacket. Y'all saw it. This is kind of our uniform as an attorney. So I have one. I'm getting a little warm now. All right. All right. So when you put in the application, you actually switch over from having to pay $10,000 a month to what we call a good faith estimate. We look at your income, we figure what your bill is going to have to be. From then on, you only have to pay what your bill would be if you're approved. As long as you eventually get approved, whether that be in 90 days or 180 or 360, that's all you have to pay. Now, if you lose, they can come back and the facility can come back and demand the payment in between, right?
That's group one.
That's group one. Group two, when we're applying for help at home or the assisted living, that's home and community-based services. They don't actually have to provide the care until you're approved. And so, yeah, if they did that and we went to a fair hearing, we got to get all the way through approval before we're going to get benefits. So usually what I would do is I would both file the appeal and I would figure out a plan B to get us to qualify and do a new application both. And that way I've got one of the 2 dates. Yeah.
Glenn, this might move away a little bit, but in the event that you were trying to avoid the look back and you were doing a revocable trust, if you were doing a revocable trust, like with your assets, like if you got 2 healthy a married couple, and one of them is needing long-term care help, would you start would a revocable trust 5 years prior start the clock ticking to a movement?
You're right, a little bit ahead.
Repeat his question.
Okay, so-
You can say.
So the question is, we've mentioned,
Sorry.
no, it's a great question. It's multiple parts we're gonna hit in the next couple. The first one, he was asking if you're worried about the 5-year look-back period, can you make a transfer to a revocable trust that will make it where that asset doesn't count in 5 years, basically? And the answer is no. Revocable trust is going to be countable in Tennessee, and it would be subject to estate recovery. In fact, a revocable trust is actually a little bit worse than owning your own name because they can count a house as a countable asset, where if you owned it, it would be exempt. Now, an irrevocable trust is a different ballgame. That one, if you gave it away 5 years later, wouldn't count as yours. But for all the rest of you, we skipped the next 3 slides.
Okay.
And so, no, that was a great question. So let me hit those real quick, and then we'll come back to that, right? It might have been the next 4 slides. So,
I got you.
but no, the good thing is you're getting to the takeaways, which I probably, yeah. This is always one of those things where I know this is mind-numbing, but if I go straight to the takeaways and I don't say the why, then everybody thinks I'm crazy. And if I tell you too much on the why, then you're gonna think I'm crazy because I spent my time, everything going into this, and you're gonna say, what's the takeaways? So I know there's people who are kind of both, but we'll go through the what, and then we'll put it together a little bit. So we talked about, in order to qualify, there's 3 tests. The first one is the income, so you've got to be below that amount or have qualified income trust. The second one is you got to prove that you're disabled enough to qualify. And so we call that a PAE, or a pre-admission evaluation. It is literally a test to turn how disabled you are into a number. Can you stand up on your own? Always, usually, sometimes never. You get 0 to 4 points, right? Can you eat on your own? They don't mean cook. They mean if somebody puts food in front of you, you can put it in a spoon and take it, right? In order to qualify, you got to score a 9, and that's pretty disabled, right? That's much more disabled than you'd have to be for, say, VA. Now, when they started this, we were turning down people who literally met the definition of senior, elder abuse for neglect. So we had to find a workaround, and that's called a safety determination or a safety assessment. So usually you gotta score a 9 on this. On that one, if you score like a 5, but you have certain carve-outs, like you can't stand up on your own, you can't, and you can't toilet, or you're constantly falling, or you're in and out of a hospital. We've got some workarounds now. Yay! So it's not as bad as it used to be, right? But this is either done by the nursing facility once you move there, or if we're applying at home or in the assisted living, you can call ETHRA, or the Area Office on Aging. They'll come out and do the assessment. Yay, right? That's good. So, but either way, a lot of people think just because you have a dementia diagnosis, you're going to pass this. You're not, right? You've got to have physical deficits, and a lot of them have to do with your ability to really physical, right? Can you stand up? Can you walk? Can you toilet? And that's tough because a lot of people with say Alzheimer's, they can do all of that as long as they have somebody to cue them, to tell them to do it. And so it can be a real issue with this test. You can tell I don't care for it very much, but that's what it looks like, right, on there. I'm also very lucky because I have social workers on staff who specialize on helping with that. So, yay, Gabe. All right. All right. So we kind of talked about that. All right. Now the last test is the asset test. This is where you were going. This isn't what you make. This is what you own, right? So kind of like I mentioned in VA, the first thing they're going to do is divide all your assets into things that count and things that don't, right? The things that don't are your home for your lifetime. And it doesn't matter if it's owned by you or your spouse, it doesn't count. As long as you have lived there and have an intent to come home. And they can't really test that, so there you go. It doesn't matter how many acres you have. So in a lot of ways, VA is the easier to qualify for, but in this way it's not, right? If you've got a rural person that's got a 15 acres, it's Medicaid's going to exempt all of it as long as it all touches each other. The second you've got another person that owns a lot in between your two lots, the second lot does count, right? So in other words, all your contiguous land that touches each other, it's all exempt even if it was 200 acres, right? But if I own this and then I own another property down the street, the second property is going to count, right? One vehicle doesn't count. Your stuff doesn't count unless it's of unusual value. So if you got the Picasso, let me know. If you got a Thomas Kincaid, I probably don't care. So no offense, I know they're very pretty. But your burial plots don't count. Your prepaid, your irrevocably prepaid funeral, burial, cremation, those don't count. But it does have to be irrevocable, right? With an itemized list of what you get. It was a big thing in the 90s that people would get these like $50 burial policies. And usually on your insurance, the death benefit's not going to count, but the amount you could get out tomorrow, the accumulation value or the cash value does. The people were buying these really big, death policies and then getting cremated for $1,000 and the rest of it went to the family. They figured that one out, right? So now it's got to be revocable. Farm equipment doesn't count if it's being used in farming. If it's a business, there's some pretty complicated rules. But in general, those are the ones that most of us have that don't count. So countable assets is pretty much everything else you've got. And so we're looking at IRAs. That wasn't always true, but it is now in Tennessee, depends on the state. Checking accounts, savings accounts, obviously, boats, RVs, annuities, gold, all that good stuff. And all of the countable, if you're single, the countable has to be at $2,000 or less. So that's one of the reasons we said there was a big difference between VA. VA were $160,000, right? Here we're at $2,000. So a lot of times we want to try to get to VA earlier and use that until we can get to Medicaid. If you're married though, they don't want they're going to have some other protections for the well spouse. We don't want them to be down to $2,000. And so what they're going to do is at the time of institutionalization, which means either you go into a hospital/nursing facility and you don't come back, right? We're going to be there for 30 days and expect it to be longer. At that time, they look at all the countable assets that the couple has, and the well spouse gets to keep half, but with a minimum of $32,000 and with a maximum of $158,000, right? So at that time, if I had $1 million, the well spouse gets to keep $158,000. Everything else has to be spent down to $2,000. right? If at the time you go in the nursing facility, you've only got 20,000, the well spouse gets to keep all of it because it's below 38, right? And if I had 100,000, then the well spouse gets to keep 50, the other 50 has to be spent down to 2. So we got a 48,000 spend down. That's the word spend down, is that amount that has to go down before you qualify, right? So the short story is they're not going to take everything. The well spouse gets to keep half generally, but with a minimum and a maximum, right? It's always going to be less than 158,000. And once you do that, then you go on, and then they're going to help pay for the assisted living, the in-home, or the nursing facility care. All right.
Those who might not know, you tell us on these leads, irrevocable.
Yeah, I was going to get the irrevocable just in just a second. But that's with no planning whatsoever, right? So the positive things, there are a couple of things that we can do for planning, one of which is the irrevocable trust. So we kind of talked about that one. There's 2 other rules I want to touch on real quick. We mentioned the look back period, right? VA has a 3-year look back period. Medicaid's going to have 5. Again, anything you spend on you or your spouse doesn't count. You can literally get on a cruise ship and go around the world 3 times. That's perfectly fine. But if you're paying for your kid to go on the cruise ship, not fine, right? They add up the total amount of gifts you made in the last 5 years, and then for every right at $8,600 you give away, if you're in a nursing home, they won't help you for 1 month. That's called the penalty period. They don't start that penalty period, though, until you're already in the nursing facility, you've already spent down, you already passed all 3 of the things. They would start paying you anyway, right? You're in the nursing facility, you pass the income, you pass the medical, you pass the asset, then they won't help you for that long. For group 2 at home, they just won't help you until it has been 5 years since the last gift. It's hard, right? Okay.
Well, then,
Yeah.
I will say this, I had a client this time, her only asset was $4,000 life insurance policy.
Right.
So they started taking her $185 for Part B premium out of her check until she either deeded that over to a funeral home or cashed it out. Which the cash out was going to be $3,000, right?
Yeah, so there's a couple of different workarounds in that. One of which that sounds like that could have been a hardship waiver that they can do if you wouldn't qualify without that. The second, the easy way to do it a lot of times, especially if she's going to be buried, you can switch over life insurance to an irrevocable prepaid funeral and burial, which is really common. The other way to cash it out, once you cash it out, then you're going to be over resourced. So you got to make sure you spend down within that month to get back to the $2,000. It's not near as hard to spend down $2,000 as it was a decade ago. I think you can do it a lot easier these days. But the other thing that he's hitting on that I think is really important, life insurance policies are the hardest thing here. Or I shouldn't say the hardest. The hardest is second properties, actually. But in IRAs, those are the 2 things that can be more complicated. The most common thing that trips people up is those life insurance policies. Because the kids don't know that they have them, that the amount, that insurance companies are slower to work with the banks, honestly. I show up with a power of attorney at a bank, and I tell them what's going on. A lot of times I can get them to expedite that. The insurance companies like taking your money, and they don't like giving it back. And it can just take longer to deal with them. If I've got somebody and we're in the wind down to the spin down, I always tell them, get on the insurance policy today, because having it where you're having to spend $10,000 a month for 2 more months because you can't spend down that last $5,000-6,000 because of that life insurance policy. Exactly on that one. The nursing facilities literally they make $2,000 a month. That's costing them $8,000 a month because they can't cash in a $5,000 cash value, right? So really be cognizant about that. Those small life insurance policies, a lot of times either cash them out, sell them to a family member. There's a couple of things you can do on that. But that's very true. All right. So the other thing about gifting, if you've got a couple, some people think, well, the husband's going to need the help, so the wife can give the money away. That didn't work. It's anything either one of you gave away. Just want to be clear about that, right? Doesn't matter how it's titled. It's both of yours. It's going to count. Doesn't matter who gives it away. All right. So the other thing is a gift is any transfer that's for less than fair market value. If I've got a $200,000 house and I sell it to the kids for $100,000, that's a $100,000 gift, right? They're going to assume the fair market value of it is the tax appraised value, which currently is quite low. So that does give us some planning options. But some people will be like, no, I didn't give him the car. I sold it to him for $100. That's not gonna work, right? So birthdays, Christmas, graduation gifts. I'll tell you, the rule itself does not have a minimus. It does not say like nothing less than $200. It just says a gift's a gift. I've never had them get mad at $150 or less for Christmases, birthdays, weddings. I've heard people say 500, but I have seen them hit people for 500, so I would not be that careful. Also, since we're in a church, I've never seen them get mad at tithing. We are in the buckle of the Bible Belt, but Illinois did turn somebody down, I think 3 years ago, for a major gift to a capital campaign. So be careful if you're on that one now. And I've had them turned down for gifts to a televangelist, but we are not going to get into that story. Unless you want to know afterwards, and then anyway, all right. So those are things. The other thing is, if we did make a gift, you can get it back, right? If I gave $10,000 to the kids 2 years ago and I need a nursing home, the kids can actually give me the $10,000 back. Now it counts, but that got rid of the gift. And we can actually have them paid back with a Medicaid compliant promissory note, where they pay you back over time instead of having to come up with it immediately. Just when I use the word Medicaid compliant, you can imagine there's a bunch of rules there. I won't bother you with them, but you can only go so far out. You can't stop it. You can't ignore it. But that's a way we can a lot of times secure these pretty quickly, right? Okay. So we kind of all talked about that. The big thing on that penalty period is we did give away $85,000. We had a 10-month penalty period. Just as a reminder, for the nursing home, they're not going to start it until I'm already in the nursing home. I've already got income below that amount or a QIT. I've already passed the PAE, and I've already spent down to $2,000, or at least that spouse is down to $2,000. Then they won't help you with it. So it's a way of kind of putting kind of force the kid to give the money back. All right. There are 4 big exceptions to the gifting rule. The first one is you can make unlimited gifts between spouses before you apply. The second is you can give money to or for a trust for a child that's on disability. So if they're on SSDI, SSI, that's going to qualify. Or you can transfer a home at any time to a spouse, to a child on disability, to a sibling co-owner who has lived there for a year. So a lot of times that's mom dies, it was me and my sister. Hey, all right, okay, I got a minute. My wife, my mom dies, she leaves the house to me and my sister. My sister still lives there. I can give my interest to my sister, right? But she's got to live there. And then the final one is the caregiver child. This one's really powerful, but it's a lot harder than people think, right? If I live in my house and I need nursing facility level of care, and my child lives into my house with me, and gives me enough care for 2 years that keeps me out of the nursing home, I can give that kid the house, right? But it has to be the 2 years immediately before institutionalization, right? So there's about 4 huge traps here. The first one is you gotta need nursing home care. This is not a child that moves in and goes shopping for you and then once every 2 weeks makes dinner. We're not going to meet the test, right? The second is they got to move into your house. You can't move into the kid's house. That doesn't do it, right? And you got to prove that. So if you're doing that, make sure you're changing your mail. The third thing is it's got to be the 2 years immediately before institutionalization, which means I'm at home, I provided care for my mom for 10 years. She moves to a private pay assisted living for 4 months, and then she goes to the nursing facility. I have had them argue that 4 months was not Medicaid, that was not technically institutionalization, therefore I cannot give them the house, right? So I was able to get that one through on a different exception, but be careful with that, right? People all think that that one's gonna work, and they only approve a handful a year, so be careful with that one, right? Okay, but it can be wonderful in those situations. I will also say, if you have a disabled child, if you give the child the house while you're alive, it's just theirs. If you don't, we can still stop estate recovery, which we're going to talk about, but it's only as long as the child lives in the house. So if the child sells it or they move out within 4 years, there's still estate recovery. So the timing on that one matters. Okay. So I don't usually hit people with that, but we've got some people in the industry here, so I wanted to. All right. Okay, the last rule that we're going to hit is estate recovery. So you probably heard that the nursing home's going to take my house or the state's going to take my house. This is what they're talking about, right? If you're on these type of Medicaid programs, but not other ones, the whole time you're on, they're running a bill. And we said they don't count the house as long as you live there and you have the intent to come home, right? So when you die, though, if I've got a $400,000 house, I'm in a very different situation than somebody that doesn't. And they want to get paid back. The big thing to get paid back from is your house, right? There's some rules here. The first one is there's no estate recovery until the second spouse dies. So if you've got a spouse that's still alive, if I'm married and my spouse is in the nursing home for 5 years, she dies, they're not going to kick me out, they're not going to come for the house. There's no recovery until both of us have died, right? The second thing is we've only got to recover up to the amount that they actually paid, or how long, based on how long their benefits. If you're only on for 1 month, they don't get the whole house. We just give them a check for $6,000, $8,000 and they go away, right? The third thing is they can only recover from some types of assets. And so, and this one gets a little complicated, but the short story, part one is if my wife and I own the house together and then I need a nursing facility, I die first. I know they can't recover until she dies, but can they recover from her estate for what they paid for me? And we've got a court case that says if I co-owned an interest in the house when I died, they can. If I didn't, they can't. So a lot of times at the time we're going to go in to qualify, we'll transfer the house to the will spouse. Right?
Is there a statute of limitations on that? I mean,
There is now a statute of limitations as of 3 years ago for 4 years. That's why I mentioned the 4 years earlier. Yeah. But you're talking about the recovery, not the transfer, right? Okay. Unless it's for improperly paid benefits, and then there's no statute of limitations. So if they find that you cheated, they can always come back. So the second thing about it, the next thing about it is they can only really recover if it's from your probate estate or in a revocable living trust, right? If I own it in a way that passes outside of my estate that's not a revocable living trust, the federal government allows states to choose to be able to recover from that or not, and currently we can't. So that means if you own it with a life estate, you own it with joint with right of survivorship with a child, if I die, we own it in a way that if I die, it's yours, if you die, it's mine, regardless of what my will says, right? And if you own it like that currently, they cannot recover against it, right? Now, we had this go up to a case on a revocable living trust 10 years ago, and Justice Cope, who said in a note that he thinks the TennCare can change this rule at any time without even going to the Tennessee legislature, but he's no longer on the court. He's running LMU Law School. But we do want to be careful about that. That's not the first type of planning I do. But sometimes I can have a kid purchase a 10% interest in the house with right of survivorship. That can make it where if they don't change the law, we avoid estate recovery, right? Same thing with a life estate. Currently, that's a life estate's a way you co-own it over time. I own it for my lifetime. I can rent it, but the second I die, my child already owns it. It passes to them outside of probate. It skips their creditors. Currently in Tennessee, 10-care can't recover from that either. Now, if I'm setting up a life estate, it's a gift, right? So you got to be careful with that. But both of those things are things that can avoid it. And then an irrevocable trust. If I owe it with an irrevocable trust, that's also going to avoid it. So,
And just to clarify, so an irrevocable trust is a trust that is locked in. A revocable trust is a trust that can be.
okay. So, I know y'all are fun. I've been an hour. But I had an hour and 15 minutes on the schedule because somebody figured I was going to go long. I don't know who that would have been. See, maybe sitting in the front, giving me a big smile. I'm going to hit real quick some common strategies that we can use so that this isn't as depressing and you know there's things we can do. Yay! Right? So that's one of the first ones. The first and most important thing for all of this for everybody is make sure you got a power of attorney. It's in place. And preferably one that allows us to make gifting in some sort if you need it. Because the rest of what we're going to talk about, there's ways that we can speed up getting qualification and preserve the money, but a lot of times you have to move the money to a spouse or a child at the right time. And if I've had a stroke, the only person that can do that is my duly appointed power of attorney, and only insofar as I gave them those powers. We don't have a power of attorney at all, and I can't make decisions for myself. We've got to go to court, have a conservatorship. Like, who's the famous person for the conservators? Yeah, that's it. So like Britney Spears, so we can't do any of that now. So the first thing you need is to have a have a good power of attorney that has the ability to do this plan, right? Okay. Part two is if I'm going to spin down and I've got spouses, and if they had $1 million that counts, instead of having to pay for care to get down to $160,000, we can actually purchase a single premium immediate annuity that's Medicaid compliant that basically turns that $850,000 into an income stream for the well spouse. We talked about the well spouse can have unlimited income, right? So I can actually spend down $850,000 in 1 month and have it with a contract that's going to pay an equal amount to that well spouse every month for a certain period of time. Now, to do that, it has to be an equal amount. You can't stop it once you start it. There's some rules to it. Also, if the well spouse dies before they get it all paid back, whatever they haven't received yet has to go to pay back the state for what they paid for the other spouse. But if the well spouse is in pretty good shape, we can set that up with a term of 2 months, down to 2 years, usually 4. But we can basically purchase that, have it pay it back, and that's under federal law that's going to be exempt. So we can spend down a lot of money fast. I said $1 million because if you got $5 million, just pay for care. Okay. So that's a really, really powerful tool I wanted to mention. Oh. All right. The second thing I kind of want to mention is there's a difference between a revocable trust, an irrevocable trust, and a supplemental needs trust, and they're all really powerful here. So first of all, a trust is a separate legal entity that can own things, right? It's not unlike a business or a corporation or charity, right? Trust can own checking accounts, savings accounts, houses, cars, what name you, right? Every trust has 3 roles. The person that sets it up makes the rules and puts the money into it. That's a grantor or settlor. The person in charge of the trust, that's the only person that can touch the money, invest the money, spend the money. That's the trustee. And then the person the money has to be spent on, that's the beneficiary. So I've got a 4-year-old. I know I'm quite old for that, but she's awesome. So she just turned 4. If I die, I want to set up a trust for her. So I want to have money for her benefit, but I want to give it to her directly because there's only so much stuff that you can buy that has Disney on it. No, I take that back. I only have so much money to purchase the portion of Disney stuff that's out there, right? And so I'm going to set up a trust. I'd have maybe my sister in charge of it, but it's only there for my daughter's benefit, maybe until she turns a certain age, right? That's kind of what a trust is and what it does. Now, that being said, there's 1,000 different types that do different things. The most common is a revocable trust. And that one, I set it up, I'm in charge of it for my own benefit. I can change it at any time, and I can terminate it, right? That one, when I die, I avoid probate. That's what people usually use it for. Now, for TennCare, if I've got the money and I can spend it on myself, it's gonna count, right? So revocable trusts do not help us at all with Medicaid planning. Irrevocable trust, I'm the one that sets it up, but I'm not in charge of it, and it's not for my benefit. So the first thing is it's irrevocable, that just means I can't change it. I gotta be careful because irrevocable can also mean things for tax planning, but that's for people that have got more than $15 million, so that's not what I'm gonna be talking about. But if that's one of you, good on you, right? So in irrevocable trust, I set it up, I give up enough power that Medicaid or VA does not think it's mine. So usually a kid's in charge of it for the kid's benefit, right? When I put that asset into it, that starts that 5-year look-back period. 5 years and a day, they only look back 5 years. 5 years and a day later, that asset doesn't count, so it doesn't have to be spent down, and when I die, they can't come back after it. So there are always, even though it's irrevocable, it can still be modified in Tennessee, but the beneficiaries and the trustee have to do it, not me, right? And I can keep enough power that I get to pay the taxes on it. So I get to give up all the benefit, but I still get to pay the taxes. Great deal, right? But we do these all the time. They're really important, especially if you do have a second property. If you've got that property that otherwise we're worried about having to spin down in the estate recovery, this is a good way you can give us enough power that it doesn't count as yours. And there's some ways we can get the money back if we have to, but you know. So an irrevocable trust is really powerful if we think we have 5 years, right? We talked about that. The last thing I kind of want to touch on that's really common is if I have 2 spouses, like we talked about, I can have unlimited transfers between the spouses, and when the first one, they only are going to have estate recovery when the second one dies, right? And they can't recover for benefits they paid for the first one if they didn't own an interest in the property when they died. So a lot of times we want to move the asset to the more well spouse, right? Well, my crystal ball is broken, and I've done this a lot, and so that one we think is more healthy may die first, right? And if they do, if I haven't done any planning, the house and that $150,000 that the well spouse can keep is all going to go back to the other spouse. Then they're going to be over the $2,000 they're allowed to have. They're going to be disenrolled, and when they die, we're going to have estate recovery, right? We can plan for that by having a well spouse set up a supplemental needs trust in their will. Now, this is a trust you can set up for anybody else in the world except for your spouse or yourself at any time. But for your spouse, you can only set it up in your will. And when you die, everything that you leave goes into a trust for the well spouse, right? That's the only person that money can be spent on. They can't be in charge of it. You gotta have a different trustee, but everything that goes in there doesn't count for Medicaid. It doesn't have to be spent down. There's no estate recovery, right? And that's really, 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 really powerful. And so the short story is there's some other things we can do too. But if I've got somebody that's got an early dementia diagnosis and we think we've got 5 years, if they're married, a lot of times we're going to look at transferring assets, updating the will, updating the power of attorney, adding a supplemental needs trust. We'll talk about an irrevocable trust. If you're single, the chances we use an irrevocable trust are a whole lot higher because honestly, we can't do the transfer between the spouses at that point, right? And that's a really powerful thing. And then there's some other things that we can do to accelerate a spin down, one of which is that spousal annuity. The other one is if I've got a single person and they've got $400,000, a lot of times I can make a controlled gift to the kids, tell TennCare I did it. I know that for every $8,500, they're going to not help me for a month. I use the other half to turn into a spin down, an income stream to pay for care. So that was a bunch, right? It's also hard because we're talking generalities, but thank y'all. There's care out there and we can get it. How's that for a book? All right, thank you.
Hey, hello again, everyone. I am Gabrielle Blake. You've already met me, and I'm going to be the moderator for the panel part of our discussion. You're going to have to bear with us a little bit because technology is fun, and these microphones, we're going to be sharing them, so we're going to be kind of going back and forth to each other. So, thanks again, Glenn, for getting us started. I had 3 or 4 people come up to me during the break and say, how does he remember all of that stuff? And it is very complicated, but you gave us a nice little overview of that. So we're going to talk a little bit more about other options for paying for care. And as I introduce the panelists, they're going to give you an overview of their area of focus. Then we're going to dig a little deeper into eligibility and what it covers and why timing can be important. So I'm going to start off with Miss Brooke. Brooke gets extra credit because she is coming to us during probably the most busy time of the year for her. She is a Medicare advisor. So Brooke Thurman is an independent Medicare advisor with Core Insurance Advisors, specializing exclusively in Medicare for the past 8 years. She helps individuals and caregivers navigate Medicare with clarity and confidence, whether that means choosing the right plan, understanding benefits, or reviewing coverage to ensure it still meets their needs. With over a decade of prior experience assisting businesses with human resources and insurance, Brooke brings a deep understanding of how to match people with the right solutions for the unique situations. She is especially passionate about guiding clients through the annual enrollment period. She's going to tell us what that is in a minute. When reviewing and updating Medicare plans can make a significant difference in care and cost. A Knoxville native, Brooke is proud to serve the community she calls home. She has been married to her longtime best friend for over 20 years and is the proud mother of 3 children, ages 15, 13, and 10. Welcome, Brooke. Most people have heard of Medicare at least, so that's a good start. Tell us a little bit about what Medicare is and how it can help to pay for care.
All right. Well, first off, this is full of acronyms. So you've already heard a lot of acronyms today, a lot of information. Medicare loves the alphabet, so you're going to hear lots of different letters, and they all mean different things. But Medicare is a federal program that, as you've lived and worked in the United States, you or your spouse, you've been paying into Medicare through your payroll taxes, but there's all kinds of pieces to this whole puzzle. So there are main parts of Original Medicare, Part A and Part B. We'll talk more about what that is, but those are the primary coverage areas, which is your hospital insurance, your Part A, and your Part B, which is your medical side of the portion. Now, that little red, white, and blue card, many of you may already have, that is Original Medicare, okay? So when people are referring to that card, those are the only 2 pieces of Original Medicare, and then there's other things you can add on to assist with your care coverage. So that would be something called Part C, which is a Medicare Advantage plan, or Part D, and Part D is really important because D stands for drugs, and we all need prescription drug coverage, so that's a good way to remember it. So those are the 4 primary parts of Medicare that will help with your coverage. In addition to that, there are things called Medigap plans or Medicare supplement plans, which some of you may or may not have. All kinds of letters. They're all different letters to add to our alphabet. So coverage for Medicare is typically through those pieces, and we'll talk more, I guess, from here on what is included in Medicare beyond that and what is not. But those are kind of the primary pieces of coverage. And then if you have received a call, let's say in the last week, from a solicitor related to Medicare, either a mail or a card, raise your hand. Anybody? Okay, we've got lots of, yeah. So Medicare annual enrollment period is from October 15th through December 7th. And what that means is that anyone that is currently on Medicare has this window of time to review or make an adjustment to their plan for January 1st of 2026, okay? So this is the window. You're gonna get calls, you're gonna see commercials, you're gonna see billboards, all kinds of information out there, because this is when they're really marketing all of the different product offerings available. And this is a nationwide annual enrollment period. So we'll start with that as kind of an introduction, and then we can get into more details.
Do you want to tell them about what Advantage plans are to the difference?
Sure. Let's talk about, so a Medicare Advantage plan is also called that Part C. And a Medicare Advantage plan is a little different because it's basically done through a private company. So all the insurance carriers, or I'm generalizing all, but in our area, multiple insurance companies, Blue Cross, Humana, Cigna, Aetna, whoever it is, are given money from the government to go out and then build their plan. Similar to how an employer might go out and offer their coverage. So they're getting money that you've already paid in for your Part A and your Part B for original Medicare, but then the plan is then creating a copay structure and maybe deductibles or a maximum out of pocket. How will they cover your prescriptions? But because it's all done through the private insurance companies and they're not billing to Medicare, they can add in extras. And this is part of what you're seeing all those commercials, because the extras can be different from different companies, carriers. Things like dental and vision and gym memberships and over-the-counter allowances, things like that that are available through Medicare Advantage plans. So the general concept of them, that's how they're structured. But then there's there's lots of different types of Medicare Advantage plans that might fit your needs. So we've talked a lot about veterans. So there are specific plans called, I call them veteran plans, but they're Medicare plans that maybe you're using the VA for your prescription coverage. So you don't need the drug coverage to be on your Medicare plan. So you might choose what's called a Medicare Advantage plan without prescription drug that's going to supplement your VA coverage, okay? So there's different plans for that. This year you're going to see a lot more what are called chronic care or chronic special needs plans. So primarily these are for people who are diabetic or maybe have cardiovascular related diseases. And those plans are, a doctor is signing off that they meet the criteria for that plan, but they might have a level of assistance in that Medicare Advantage plan to help you care for those special needs. There might be a food allowance given to you for healthy foods, or some extras that you wouldn't see in just a typical Medicare Advantage plan. So if you meet those standards, that's something to consider. Another common one that we're seeing more of is called a give back plan. And so we know there's a Medicare Part B premium. Many of you probably are aware of this. Part A, typically you do not have a premium if you've paid and worked into the Medicare system. But Part B, everybody pays a premium unless they qualify for TennCare, Extra Help, Medicaid, some level of assistance. And with the Part B premium, a give back plan will give you back a portion of what you paid in to your Medicare. So those are it's another way, if someone, think of it kind of like a high deductible health plan. If you've heard of that, you might choose that you like the idea of getting that give back, but you're probably going to take on a higher risk personally for your maximum out of pocket or your co-pays. So there's always trade-offs in how the coverage works. But that is one that we're seeing more and more of those give back plans. There's also what are called dual special needs plans, which would be for people that are eligible for both Medicare and Medicaid. And I love Glen's, people get those very confused. I love how you said care and aid, because that's such a great way to remember. But if someone has both of those, Medicare and Medicaid, then they could be eligible for a different level of Medicare assistance under that dual Medicare Advantage that will pay for more substantial portions of their healthcare and medical needs and prescription needs. So that's a lot of information.
That's awesome.
And it is a complicated program, and you are right. There's something about the government that likes like A's and B's, and wait till we get to Bryce's. In just a minute, you're going to really see some abbreviations. So thank you for that. We got introduced to Brooke from our dear friend Kathy Goff, and she came and she presented at one of our support groups. We have a support group at Church Street for caregivers, and we offer education as part of that, and Brooke did such a great job of explaining something that can be so complex. Brooke, I think you also gave us a handout maybe over on the resource table that you can, oh, look, there's Vanna over there, otherwise known as Erin Blake, can have that over there. So thank you for that. Now, next we're going to shift, and we're also going to talk about another type of insurance with Nancy Hertwig. Nancy is, of course, a church member here, and I met Nancy years ago when Glenn and Nancy and I were doing a presentation about long-term care and the importance of planning ahead. Nancy Hertwig is a financial professional with New York Life Insurance Company, a financial advisor with Eagle Strategies LLC, and a registered representative with New York Life Securities LLC, New York Life Companies, and serving clients for 36 years. Nancy's credentials in the industry include designations as a charter life underwriter, a chartered financial consultant, and a chartered advisor for senior living, all from the American College of Financial Services, as well as a long-term care professional designation through AHIP, a national trade association for the health insurance industry, offering specialized education in the field of long-term care insurances. Nancy and husband Bob have been married 44 years and have 2 children and 5 grandchildren, and are longtime members of Church Street UMC and in my Sunday school class at Open Doors. So Nancy, long-term care insurance is something that I think many people know is out there, but maybe they don't know exactly what it is or what it does. Can you kind of give us an overview?
Sure. So, is that close enough? Right here? So, long-term care is for a condition that is expected to last longer than 90 days. It's not going to help you if you have a hip replacement surgery or something of that nature. It's for a chronic condition. Different companies have, and just as she was speaking about, different companies have different waiting periods. All of them have some waiting period or deductible that you pay the cost for a given amount of time before the policy starts to pay. Typically it's 90 days. Some companies have 100 days. There's other variations, like I think the majority of plans are reimbursement. In other words, you pay the cost of your care, and then after you've met that deductible, you're reimbursed month by month from the policy. It's the policies, you have to decide how long you want to cover a potential loss. When I first started selling this product, and New York Life has had that product for over 30 years, you could get one that was unlimited in duration. Those policies just don't exist anymore. So about the longest you can find coverage for is 6 or 7 years, depending on the product. You buy it not only with your dollars in premium, but you buy it with your health. You have to be qualified health-wise for that. And as Glenn was talking about in his presentation, there are 6 activities of daily living. They're referred to as ADLs, alphabet soup again. Bathing, eating, dressing, transferring, toileting, continence. And
to qualify for benefits, one must need help with at least 2 of those activities of daily living, or have substantial cognitive impairment such that you're not safe in an environment by yourself. You might wander off, you might leave the stove on. So those are standardized in the industry. Those are the criteria and what makes you qualify to begin receiving benefits within the industry. Doesn't matter the company you buy from. So that's a big overview.
Awesome.
Thank you, Nancy, for that. Long-term care insurance, whenever people come into our office, we have a packet that they fill out, and sometimes people look at that packet and they go, why on earth are they asking all of these questions? But one of the questions really relates to long-term care insurance, and whenever we see a person has that, we're like, yes! Because what we find is when people have that, they're gonna get the care they need sooner. And as counterintuitive as it sounds, people who get care sooner actually stay independent longer. And so we're so glad that there's people like you in the industry who are really helping people to make informed decisions about that. Well, I have known Bryce Terry for a few years now, and she is one of the smartest people I know, and when you hear her talk about this complicated program, you're going to understand what I mean, because it is so complicated, and she is great about giving me emails and text and saying, hey, here's this new part of what's out there with White Card. So I'm going to introduce Bryce. Bryce Terry Murdoch is a dedicated EEOICPA. Okay, let me do that one more time. EEOICPA specialist for Maxim Healthcare Services with a unique perspective for senior caregivers. Leveraging nearly a decade of experience in senior care, she has focused exclusively on the Energy Workers Program since 2020. Bryce understands the challenges caregivers face when helping their loved ones navigate their White Card benefits. She works to ensure eligible seniors, particularly those who worked with the Department of Energy sites, receive the medical benefits they deserve by providing crucial support to both seniors and their caregivers. Bryce, this is a complicated program. I'm just going to call it White Card because I think that's what most people do. Likewise, when I said, we have this intake packet, when I see people pull out that White Card, my eyes just get big. I'm like, yes, we have some services. So tell us a little bit about that program.
Yeah, there's actually a lot of it about this program. Yes. So the Energy Employee Occupational Illness Compensation Act, or the Energy Workers Program, also known as the White Card, is for former or current Department of Energy employees or subcontractors who have been diagnosed with an illness that was caused by some type of toxic substance exposure. The kind of rule of thumb is that if your work took you within the fence of an eligible Department of Energy facility, you can qualify for this program. So locally, those sites are going to be Y12 National Security Complex, X10, which is now Oak Ridge National Laboratory, and K25, Oak Ridge Gaseous Diffusion Plant. When approved for the White Card, it will cover 100% of all medical costs that are associated with the claimant's approved conditions. This includes services for long-term care, which can be up to 24/7 care provided by a certified nursing attendant, a licensed practical nurse, or a registered nurse, or anything in between. In addition to medical benefits, the EEOICPA offers up to $400,000 in monetary compensation. There are two parts of the program, Part B and Part E. For a claim to be successful through this program, or either part, the Department of Labor is going to require a proof of illness, which can be a medical test confirming the diagnosis, employment verification, and a probability of causation that is at 50% or greater, which means it's at least likely as not that your illness was caused by a toxic substance exposure. So Part B is going to be for illnesses that are caused by radiation, beryllium, or silica. So this is where a majority of the cancers are going to be filed. The claimant's case will be referred to the National Institute of Occupational Safety and Health, or NIOSH, for something called a dose reconstruction rating. So for Part B, this is how they establish that probability of causation. So they look at a number of factors such as the employee's work history, how long they worked, what they did, and it'll end up yielding a percentage. If it's 50% or greater, that means that the claim will be moving forward. The monetary compensation offered through Part B is $150,000. So for Part E, it's for illnesses that are caused by any other toxic substance exposure. This can be things such as organic solvents, heavy metals, and things like asbestos. The types of illnesses that are covered under this part are things like COPD, asthma, chronic kidney disease, Parkinson's disease, neuropathy, and many other illnesses. There's actually not a list of eligible conditions. Technically, you can file for any illness. The caveat to that is that you have to prove that the illness was caused by a specific toxic exposure during your employment at the DOE facility. So the way to determine the probability of causation for this part is by working with your physician to write something called a causation letter. And all this is basically connecting your illness to that toxic substance exposure. And it needs to show that there's a causal relationship between the two. The monetary compensation for this part is up to $250,000. So when filing a claim, the burden of proof is put on the claimant. This means that it's up to you as the claimant to prove the exposure caused the illness. The Department of Labor does not do that for you. They'll only work what you've sent in. So you have to establish that burden of proof. So this portion of the claims process can be incredibly difficult. There are local advocates that can help claimants through the process for a contingent fee, and that's 2% for brand new initial claims, and then no more than 10% for denied claims. And then because I work for a home care company, I'm not able to help claimants actually go through that process, but I'm very happy to get you a list of the advocates local to the area that can help.
That's awesome. Yeah, as you can tell, it's a lot. And if you worked in any of those locations, I think the most important thing for you to know is that you could potentially be looking at this and to start doing your research now.
So, and I will say, they like to see 250 days of employment at the very least. It is kind of like contingent on what illness you're applying for, but 250 days is about a year of employment. So if you have that prior to about 1995, then you can qualify for at least something as long as you have an eligible illness.
What's the date that they switch over for the presumption? If you worked at it before a certain...
So are you talking about special exposure cohort?
Yeah.
Okay, so there is a piece of this program called the Special Exposure Cohort, or SEC. Each one of the plants have different dates, so I'm so sorry I do not have them in my head today. But there are 22 different types of cancers, and if you worked at that plant's respective SEC dates and you've been diagnosed with one of those cancers, that basically means that you get to forego having to be referred out to the NIOSH dose reconstruction rating. That 50% or greater is just automatically assumed because you worked in those dates. So I do know that K25s, theirs is the easiest for me to remember. So if that person worked at K25 for a year prior to February 1st, 1992, and they were diagnosed with colon cancer, that means that they are SEC eligible as long as they can show, proof of their illness and their work is verified. That means they're automatically getting approved. So instead of it taking about 15 to 20 months, you're looking at more along the lines of 4 months until approval.
Sorry, I was spending my Friday talking to somebody trying to decide if it was in the late 80s or early 90s. So it was more convenient than looking it up. She's sitting right here.
Yeah. See, even the panelists, we learn from each other, so that's good. Well, Glenn, obviously the audience knows you now, so we're going to kind of start into our next question of really what types of care does your area focus? And you shared with us a little bit about the options for coverage for the VA and for the Choices program, and you talked a little bit about direct care. You didn't specifically talk about Ben Ashley. Could you touch on that a little bit?
Yeah, that's a good one. I was thinking about that on the way over there. So we talked about veterans, and it's kind of a little bit complicated there, but one of the greatest benefits we have in this area is Ben Ashley's Veterans Home. It's out in Hardin Valley where I live. It's between Knoxville and Oak Ridge.
It's
And-
right around the corner from Morning Point of Hardin
It
Valley,
also
where
is,
Megan works.
Yeah, it's right there.
Just visit Megan on the way.
It might be my favorite nursing facility in East Tennessee. It is just beautiful. It looks more like an assisted living. The staff there they get state benefits, so I think they hang around a little bit longer. It's got a real mission purpose to it. I think also for men, it can be nice because ladies, y'all do better than we do. And so when you get to the nursing facilities, they're mostly female, right? Or not mostly, but I'd say overweighted heavily. And the thing about Ben Ashley too that's really nice is it's not an actual VA facility. We talked about if you're 60% service related, you can actually get VA nursing facility. Well, the one you think about in that's really Mountain Home in Johnson City. That's the one that's direct VA. This is actually run by a nonprofit. We'll call it the State Veterans Home because it's partially under state and nonprofit and VA purview. The good thing about that is any veteran or veteran spouse can qualify, right, to go in there. And it's a wonderful facility. Now, if you're not 60% service related, you're gonna have to pay, right? The veteran gets a discount off of that, but long-term care insurance can help, Medicaid can help pay for that, obviously aid and attendance is there as well. And for a veteran spouse, they can also qualify for that. Now, all veterans get a stipend off the price where a veteran spouse has to pay the full freight, but it's a wonderful resource that we have in this area. Now, the negative is everybody seems to know that it's a wonderful resource that we have in this area, and so there's a long waiting list. It can be hundreds of people on there, and there for a while they weren't taking people on the waiting list.
They're not
They're
taking.
still not. But a lot of times the way that you get in is if you have a hospitalization for 3 nights, you're getting skilled rehab in a nursing facility. Nursing facilities get paid more from rehab, right? So Ben Ashley a lot of times will take people for direct admit for the rehab, and then at the end of the rehab period, if you need to stay, a lot of times you can long-term, or usually you can long-term. And that's where Gabe comes in more than me, so that's where she was getting excited to
Yeah.
So, but that's a wonderful resource that everybody should be aware of.
And this sort of brings up one of the tips that you will hear us talk about in these caregiver workshops every single year, and that is to start doing your homework now. Start a legacy drawer or a legacy file where you have a copy of that discharge paper, where you have copies of your employment record, where you're going to put a copy of your long-term care insurance policy, where you're going to have copies of your Medicare and your other insurance cards for your loved ones, because that's going to make it much easier later when you're putting forth a claim or you're doing an application or you're meeting with someone like Megan to enter into an assisted living. You're going to have all of that together now. And as Glenn mentioned earlier about life insurance, one of the big delays that we see is people getting an updated statement about your life insurance. Go on and ask for that now so you have it. Now that kind of brings us back to Brooke, and we're going to ask each person to kind of tell us a little bit about what types of care your area might cover, and are there limitations or restrictions to that coverage?
Oh, the fun part, right? Okay, so we talked just briefly a minute ago about what the Medicare parts cover, but again, Part A is really talking toward or working towards coverage of your inpatient hospital care, right? Part B is things like your doctor's office visits, if you needed physical therapy, if you've got, anything on that medical realm, that's your medical portion. And then Part D is your drugs. But what does that not include? Things like dental and vision, that's, your eyeglass contact lens, vision coverage. Medicare will cover things for, glaucoma, if you've got retina-related macular degeneration, something like that. That is a medical portion of your vision, but it is not just your regular vision screening, so that is not covered. It also does not cover hearing. Hearing aids and hearing care is not typically one of original Medicare's coverage areas, so that's something to keep in mind. But one of the biggest surprises to people is they think, okay, well, where does the assisted living come in? And, where does Medicare pay for that? Medicare does not cover, long-term care, assisted living care. The only portion that is covered under Medicare is what's called skilled nursing or rehabilitative care, which many of you all probably are aware. So that would be most often you're in the hospital, you're not quite strong enough to go home, so you're sent to a skilled nursing facility, what Glenn was just talking about, for rehabilitative care. And that is a short period of time, up to 100 days. Medicare does not cover it after 100 days, where you gotta work hard to stay in there under skilled nursing. Slowly get better. I tell people, slow. Do not race. If you feel like racing, don't race. You slowly get better in skilled nursing, because you meet a metric and your then insurance says, hey, you met the metric. You're ready to go. So, but skilled nursing care, it would be, NHC or life care, places that are set up for that rehabilitative short-term care. So those are some of the limitations with Medicare that we primarily see. Anything else you want to?
There's a new pilot program that some of the care agencies are doing, and this is something I brought up to Brooke. Senior Helpers, Right at Home, and Synergy have a pilot program for people who have a dementia diagnosis, people who are living with dementia. They have traditional Medicare, and they are not on hospice. And it's a respite program. Over by where my Vanna White, Aaron Blake is, there's 2 different handouts that really explain how to use this program. It's per calendar year, and it's in-home care. So when Glenn shared with us that in-home care could be $35 an hour, it's a pretty nice benefit, and it's something brand new that's happened within the last calendar year. So we are starting to see more of our clients apply for it, and it's pretty huge, but it is only for people with traditional, who have a dementia diagnosis, and who are not under hospice care. Nancy, we're going to have you bring that one over to Nancy. Yes, thank you. Long-term care insurance. You've already shared with us that really when we are getting long-term care and we're placing that claim, it's because we are having that continual care. But what kinds of care might long-term care cover, and are there limitations to that?
Well, again, it's standardized in the industry. You must need assistance with at least 2 activities of daily living, and that can be standby. Like, for instance, stepping into a bathtub, you could easily fall down. And so maybe you can bathe yourself once you're in there and seated, but you need somebody helping hold on while you're getting situated for that. But standardized in the industry, needing assistance, even standby with 2 activities of daily living or that cognitive impairment.
So that can be help at home, assisted living, nursing home?
Yes. Depending on the policy you purchase, some policies cover what's called informal care. Somebody from church that could use a little extra money that loves to visit with people. You make your own agreement on what hourly rate they require. The beautiful thing about informal care, there is no waiting period. So if you go through, you have to submit an application to open a claim. And if your conditions are validated and you're approved, then there's no waiting period on that informal care. We use that for my mother. She was in our home and our daughter-in-law came during the day so I could continue to work. And so it covers, not all policies do. You have to know what is covered under the policy you're looking at, but they all cover care from a facility, a community facility that has people to come into your home, but it's through an agency, not informal. So that's the next level. More than 50% of New York Life's claims are in-home care. Most people want to be at home as long as they possibly can. And there does come a time sometimes when you're just not safe in that home environment. You need more care, and as Glenn referenced, if you're needing 24-hour-a-day care, that cost is going to really exceed what a facility cost would be to have 24-hour-a-day care. With ours, I know 4 hours of care equals a day when we're counting that deductible period. What was the initial question? I want
That's
to make
good.
sure I covered it.
What kind of care it covers and if there are any limitations. And I think you hit on that, and really the importance of when the industry started these policies, they were kind of all over the place. So people really need to get that policy and see what it covers, right?
Yes. As I mentioned before, initially, they weren't limited in duration. You could purchase a policy that it didn't matter if you needed care for 20 years. It paid as long as you needed it. It was a product when it was initially, actuaries had to estimate how long the average person would need care and try to place a premium that would keep a company whole and not have them go out of business. And it was a trial and error. But now the statistics are pretty solid. The U.S. Department of Health and help me out here.
Health, Human Resources Agency.
Yeah,
HHS.
Yes, HHS says people over 55, there's typically 70% of us will need some level of care before we pass away. So the probability is great that we will need it. And some, of course, much less than others. We all have known people with memory problems that have been in an assisted living or nursing home for a decade. And then we have people, I know I personally have had clients that passed away in, a month's time after getting into a facility. So it's become much more solid though so those earlier policies, premiums just kept going up and up and up because they were not, the companies just didn't know how to price it initially.
And they aren't inexpensive products, right? I want to say that. There is a cost to them. However, when you look at what they cover and how long they would cover it, it ends up being a decision that a lot of people choose because the likelihood of them needing care is so high. And Nancy shared with me a long time ago, she said it's especially important for women. We tend to outlive our male counterparts, and especially important for us to consider getting long-term care insurance. Now, Bryce, you talked a little bit about what the program is and how we can potentially get it. What are some options for what kinds of care it would cover?
Yeah, so the white card will cover 100% of any and all services required to treat the patient's approved conditions. This includes in-home care, doctor's offices visits, medical treatments, hospitalizations, ambulance services, durable medical equipment, drugs prescribed by a physician, both generic and brand name, even assisted living facility, and then it will also cover travel to your doctor, hospital, clinic, or any other medical facility through something called mileage reimbursement. There can be limitations or at least restrictions for coverage. The white card will only cover services related to the approved diagnosis. Most services relating to long-term care will also require something called a prior authorization. So to be approved for care, the patient must have a face-to-face evaluation with their physician within 60 days of the authorization request, and the patient can only be seen for their approved conditions. The physician will be required to then write a letter of medical necessity to justify the request, and then it can take 60 days for the authorization request to be approved. So when really you're all in, including the face-to-face evaluation, the time that it takes to get that appointment, the time that it takes to get that paperwork, that documentation back, really you're looking at about a 90-day waiting period for them to say, okay, you're good to start care. So to ensure that there is adequate medical documentation to justify the request for services, I do recommend that you be seeing your doctor regularly. You need to be talking about the approved conditions. You need to be talking to them about the symptoms that you're experiencing, because if your medical documentation says you're fine and everything is good, the Department of Labor is not going to approve that request for care. We have to be able to show that there is some type of regression in your approved condition. And honestly, one of the biggest hurdles to getting these requests approved is a lack of strong medical documentation and a paper trail of your illness. And then another point to consider is that under the current EEOI CPA law, you have to see a physician, an MD or a DO. That is the only person that they'll accept a letter of medical necessity from. So if you are someone who is seeing a nurse practitioner or a physician's assistant, you essentially don't qualify for care on that basis alone. So you do need to be seeing a physician to utilize and have access to your white card benefits.
And Bryce mentioned this as a tip earlier when we were talking prior to our workshop starting, and I think it's just a great tip for all of us to know, because all of the different programs are going to look at your physician records. If someone is wanting to get home health with their Medicare, the doctor is going to have to show medical necessity for that. If we're doing a long-term care insurance claim, they're going to ask the physician to write a report about what types of care are needed. If we're looking at the Choices program and that PAE, that medical test, they're going to ask for the doctor records. So having a relationship with a medical provider and not doing the Southern thing of I'm fine, I'm good, or downplaying symptoms, this is not the time to do that. And I'm not saying you need to be, hypochondriacal about it either, but being frank and honest. And if you are with a loved one that tends to downplay symptoms, maybe you're the collateral informant and you're there able to help understand, okay, you know what, you said you didn't fall, but you fell 3 times last week. You're there able to help with that. The other thing we've started doing in our office is for folks who are going to be putting forth a claim for that Choices Group 2, so if they're in the home, They haven't been in assisted living where they have the nursing home staff having all of their documentation about falls and agitation. We encourage family members to start a little log. Okay, well, I was with Steve the other day, and he's my person that I'm gonna keep a log about, and he fell the other day, and oh, you know what, he forgot to take his medicine the other day. I'm picking on Steve because I know Steve and I can do that. So that's always important.
So Gabe,
Yes.
one thing that I will add too is we actually have a lot of claimants and patients that when they have their white card, they'll go to a physician just to see them for their approved conditions. But then they'll also have another physician or a nurse practitioner that they see for Medicare. It just kind of separates the two out. So that way, whenever you're pulling that medical documentation from the doctor that's seeing you for your DOL benefits, it's only on the basis of your approved conditions, and it does tend to make things a bit easier when you're asking for like DME, even oxygen. You know, if you're approved for COPD, asthma, lung cancer, any of those, like oxygen can be kind of a given. You still have to go through a PA request, and I know there's a DME company that I've seen them get it the lowest, and it's still 30 days. So that's kind of intense. So I do just kind of recommend making sure that there's really good, strong medical documentation on your approved conditions.
That's awesome. Good tip. So when is the right time to make an application? When's the right time to start the process, and who would you go to for help? So again, I'm going to kind of start with Glenn. So if we're doing choices or VA, when's the right time to consider that, and who should people go to for assistance?
So it depends. Sorry, she's going to laugh at me because that's the said it.
Lawyers answer that question always.
First day
It
of law
depends.
school, the two things they said, the answer to every question is it depends, and look to your left, look to your right, one of you will be here the last day. So both of those things were true. And so, you know, I mean, the first thing is if we're worried, not just worried, if we're aging, or especially if we do have like an early dementia diagnosis, that's a point where we can do some planning. You know, we talked about an irrevocable trust, we talked about a power of attorney, also an advance directive for health care, or you know, that supplemental needs trust. Some of that planning we want to do 5 years out, because that 5-year look back period, or 3 years out for VA. And so that doesn't mean 5 years out before you need care, but it does mean 5 years out from when you couldn't pay for it, right? So a lot of times when we have those early diagnoses, when we're worried about those, we want to have the tools in place today so that we can make those decisions later, because we don't know when you're going to have the fall. We don't know when you're going to have a car crash. We don't know when you're going to have a stroke, and we need care then, right? And our crystal ball's broken. So if you've got one that you're willing to let us borrow. But so that's the first thing. The second thing then is going to be at the time that we actually need the care, right? If we've got a spouse, like we talked about, we've got some really powerful tools to be able to accelerate, you know, Medicaid qualification. But usually for Medicaid, it's going to come down to when you medically qualify, when you pass that PAE. I can do a lot of planning with income and assets, but if you're not going to be disabled enough to qualify, it's not time yet, right? That's the one that kind of has its more, that's going to determine the timeline a little bit more. And same with VA, but like we talked about with VA, you can be a lot healthier and qualify for VA benefits. So a lot of times we'll set up and try to get the VA benefits to help pay for it, in-home care or assisted living, hopefully for a number of years before we get to the point where we need the Medicaid benefits later.
Who can help you with the applications?
Well, of course we can, or elder law attorneys in general. There's us, Elder Law of East Tennessee also does the applications for you. There's a couple others that'll give you a letter and say, this is how you do it, you're on your own. Most estate planning attorneys won't touch this. If you're applying at home, ETHRA, the East Tennessee Human Resource Agency, you know, the local Office on Aging, they can help you do the application and submit it. Same thing in an assisted living. If you're in a nursing facility and the nursing facility takes Medicaid, they can also help you do the application. Now, they're not gonna do any of the strategies to accelerate qualification or save the home when you pass, that's legal work, right? But they can help you do the application.
And Rachel works at Island Home, and they have a great business office manager there, and that's the person who's going to help you get all of the financial paperwork together. They're going to have the nurses to do the PAEs. They're going to do all of that piece. And if you're looking at veterans benefits, if you're looking at applying for aid and attendance, the state of Tennessee has an Office of Veterans Affairs. We're not talking about the VA, we're talking about the state of Tennessee Office on Veterans Affairs. They have regional offices. Theirs is over by Park West. Bill Hauser and Charles McGee help with these applications. They do it free of charge, and they can help to make sure you get all of the paperwork together. Brooke, now if I'm looking at Medicare, when's the time that I need to be doing that, and who can I go to for help?
Okay, so obviously right now, if you are on Medicare and you have an Advantage plan, a prescription drug plan, a Medigap plan, this is the window to review. And I'll just say really big, important part, especially if someone has complicated medications or changes during the year, you want to do a review because the drug companies especially can change formularies year to year. They can change the tiers that your drugs are on. So it's really important for you to just understand, would it have been less expensive for me to be going to Kroger this year versus CVS? Or should I switch plans going into next year? So for right now, if you are already on Medicare and you do not have an agent, you either need to work with an agent or work with, there is also a SHIP office, which is State Health Insurance, something or other. But they will help you review. Agents are, in most cases, no longer being compensated for prescription drug plans, but it's really important piece. So make sure you get good advice on that during this window. If you're turning 65 or you are getting close to retirement, I do a lot of that when people are getting close to retiring and they are so excited about not having to worry about things, and then they realize how complicated all their decisions are. Because there's a lot of things you have to decide that are a big deal. And so usually 3 to 4 months out prior to if you know you're going to retire, that is a great time to start gathering information, working with someone to figure out what paperwork you're going to need. If you're working for a large employer, I'll say quickly, large employer is 20 or more employees. You can continue as long as their creditable coverage meets Medicare standards. You can continue on your employer coverage beyond age 65 and avoid any kind of penalties. If you're working for an employer with less than 20 employees, Medicare says we should be primary and you need to be on Medicare. So 20 employees is the little kicker for the government. But planning and being educated on what your options are and doing a continual review will give you a lot of peace of mind that you understand what your coverage is and that you're making choices that are best for you. You might talk to your friends and neighbors, and everyone's going to have different thoughts on, their own personal health and situations. We love to talk about the crystal ball. I reference it all the time. We don't have one. I wish we did. But it would help us all. But there's just a lot of things that come into play with your individual decisions related to your health history and your family history and your personality and your, just comfort level. So there's a lot of pieces to the puzzle, but reviewing and working through that will help give you peace of mind.
Awesome. Thank you. And Nancy, when we are doing a long-term care insurance claim, is there anyone that people could go to ask for help with that?
Well, because of HIPAA, the only way I can help a client with that, going through that process, is to have a HIPAA form signed by the client. The process has changed, you can imagine. Now they have an intake. It can be done by phone or the client can complete it on their computer. But most people that are at a point that they require assistance don't have the capability of the computer. And even the telephone, I have done three-way calls with the client, but they have to be able to provide, it's a lot of information that they're asking for.
So Megan and I were talking about this earlier, because you're right. Once you need the help, especially if you don't have, one of these big fat Greek wedding families where you have a bunch of people coming out of the woodworks ready to help you, it is a challenge. And Megan and I were sharing business office people at your assisted living or at the nursing home or even in your home care agency. A lot of times those people will help you with that application process. But again, they need to know you have that policy and need to know what it says. Bryce, who can people go to for help with this program? As you've already shared, it's pretty complex, and how do you know it's the right time to start that process? And then we're going to take some questions from the audience.
So as far as having someone to help you actually through the claims process, I have a couple of different answers, because really it's going to depend on the type of claim, what illness you're filing for, and how much your help or assistance you're going to need through that process. So, Gwen mentioned special exposure cohort earlier, and I went over that, and it's a fairly simple claim. You prove you have the illness, you work during those SEC dates at your plant's respective time, and that's it. You get approved. I really don't feel that you would need that much help unless you needed help with the actual paperwork. So there's actually a really great place over in Oak Ridge called the Oak Ridge Resource Center. It's kind of a division of the Division of Energy Employee Occupational Illness Compensation. So they are attached to this program. They can actually help you fill out the forms. You just bring in your pathology report. They help you go through the employment verification. They would send everything in for you. And as long as all of that stuff is confirmed, once it gets to the Department of Labor, you're good to go. Now, if it comes to like a Part E claim where you are having to establish that probability of causation on your own, I do recommend the use of either an advocate or an attorney to act as your authorized representative. So they would basically help you formulate that causation letter on behalf of your physician, because it's actually so much more complicated than it even sounds. So it's not enough to say that, it's as least likely as not that this person's Parkinson's disease was caused by an exposure at the plant. Like, you have to be very specific. This patient was a machinist at K25 from 1980 to 1988. They worked in this specific building. They did this labor process, which exposed them to this specific toxic substance. And then you have to attach something called supporting articles to that. So it's essentially a research paper, to be totally honest. And they actually do look at the work cited. Like, they're going to look up and make sure that the argument is sound. And that can be tough, even for a physician, because their background isn't necessarily in, occupational hazards and toxic exposure, right? So I do think for Part E claims, just because that threshold of proving it is going to be quite harder, I do recommend the use of an advocate or an attorney. And that payment is relatively low. It's contingent on the fact that they get you approved. So if you go through the entire claims process and they can't get you approved, the only thing that you're out is the time that you spent with them trying to work on it. So if they do get you approved, if it was a brand new initial claim, it's never been filed on, the most that they can charge you is 2% of whatever you get from the Department of Labor. And then if it's a previously denied claim, it's no more than 10%.
Okay, folks, we have talked about a whole lot, and I know you all have some questions. What we'll do is, if you have a question, kind of shout it out. I'll repeat it back just so that the filming can show that, and then we'll punt it to one of our panelists. Questions? Yes?
At what age should we start looking at long-term care insurance policies?
That's a great question. At what age should we start looking at long-term care insurance policies?
So the answer is as soon as you can, because, you know, it's based on your age and your health. The average currently is age 53, but it is trending lower. We're having more and more people in their 40s, mid to late 40s. That's not to say you can't get a policy when you're much older than that. My own mother got hers at 84.
Oh, wow.
But again, you do have to pass that medical. And so the longer you wait, the greater risk that you will have some comorbid factor that would prohibit you from being approved. And your premium is higher. The older you get, your premium is higher.
You will also look at factors that relate to your premium. A lot of the agents, a lot of the carriers are sending out letters about, do you want to lower your coverage and lower the cost of premium? What do you say about that? Is there a rule that you tend to go to for that?
No, not really. What you're referring to is the much older policies that have periodically raised the premium. They can't arbitrarily, just any company can't arbitrarily raise a premium. It has to be, their request has to be submitted to the proper people in the state that you're in. It has to be approved. They have to show proof of why they need to. They can't single any one person out because they've had claims. In fact, once you go on claim and are receiving benefits, you're on premium offset. You're no longer paying premiums. But, okay, I go down rabbit trails. I'm sorry. Tell me
No,
the
that's
original
okay.
question.
I think that what you're saying is a lot of times when these older companies will send out those letters that say, do you want to reduce your coverage and reduce the premium, you really kind of have to weigh the options. And if you're 95 years old and about to start into care and assisted living, that's probably not the best time to lower your coverage, right? Just continue to pay until you get that claim approved. So you have to factor those things.
You do, and those have slowed down a little bit just because companies had bigger increases, and you know, what they're trying to balance, what companies are trying to balance is staying profitable and still being solid financially to pay out the claims. Claims have greatly exceeded what companies ever thought they would be.
We are living longer and we are living healthier. Conditions that were once acute are now chronic. All right, what other questions do you all have? Yes, back there, Jean.
Yes, this is a question for Brooke. You touched on the Medicare Advantage plans. Can you talk a little bit about the differences, like the basic differences in an Advantage plan versus the traditional and Medigap?
Yeah.
And why a person would choose one over the other? And then once you've chosen the process of switching.
Okay, great question. I know this is hard enough. There's so much information. Okay, so typically once you get your original Medicare, you are choosing, most people get some supplement, and you're either going to pick a Medicare Advantage or you're going to have a Medigap and a separate prescription drug plan. And they're very different in how they work. So we'll start with the original Medicare and the traditional coverage of a Medigap. So what happens in that pathway is that they are working together. So when you go to the doctor and you've got original Medicare and a Medigap plan, they can only cover what original Medicare covers because they're working and billing them together. So that's why they're kind of tied in. And then you have a separate prescription drug plan. So that type of coverage is kind of the government has decided how it works. So if you have, the most common two plans are what's called a Plan G, or now we're seeing a lot more Plan N. If you have a Plan F, that was a plan, it's no longer available after 2020 unless you were eligible prior to that. But those plans were covered at 100%. But say you have that Medigap coverage. If you live in Tennessee or Texas or California, your Plan G, for instance, is the exact same. It works the same in any state you're in. And the biggest difference is that you are no longer under a network. You can see any doctor anywhere in the country who accepts Medicare. It's just the plain. Now, it's going to cover you for whatever is under original Medicare. So you're not going to have those extras that are in a Medicare Advantage plan. Things like the dental and the vision that we talked about. But you can go to any doctor anywhere in the country. You're going to pay a higher monthly premium, but you're going to have a lower out-of-pocket cost on a Medigap plan. So it's important to kind of understand. So based on how your health situation is, you're financially, there's a lot of cost difference. So that might be something that's important to some people, where other people, it's not as big of a factor. But so cost, coverage, also you have a one-time, what Medicare calls is a guarantee issue into a Medigap plan. So they don't ask you any kind of health questions the first time that you're joining Medicare if you go into a Medigap plan, because you've got that guarantee issue opportunity. But say you wait 5 years, you wanted to go on a Medicare Advantage plan, Part C to start with, and you want to go back to a Medigap plan, you would then have to answer medical questions, underwriting questions, and they can decide whether to either charge you more premium, accept you as you are, or they could decline you. So when you're going into Medicare, you're sort of picking a pathway of how you plan to pay for your coverage and what your needs are, and you've got to be comfortable with one of those pathways. Could be the way that you're always there. There's never any underwriting for Medicare Advantage, the Part C plan. You can switch Medicare Advantages during this annual enrollment, like what we're talking about now, and you can adjust as your medical needs adjust, but you may or may not be able to qualify back to that Medigap coverage. So that's a big distinction that people need to understand. Doesn't mean that you don't have coverage in either of those categories. It just means you're going to be paying differently. And that little crystal ball, if we knew that you were going to, pass away overnight and never need your health care, it'd be great. But we don't always know what those scenarios will look like. So you have to know kind of on a Medicare Advantage plan, you're going to have a copay structure, a maximum out of pocket. You're going to follow a network of providers, which is really important to make sure you can see the doctors you want to see. There are HMO plans and PPO plans, so that's related to the network. And then you are, kind of subject to that plan. So they may have prior authorizations that are more stringent than you might see on original Medicare. Things that I say that a Medicare Advantage is more similar to an employer plan that a lot of people have been in, because it is structured very similar to that. Does that answer kind of the gist? All right.
And practically what we see, especially for that skilled rehabilitative care, is the people who have that traditional Medicare get a lot more care, a lot longer stay than a person would on an Advantage plan. Advantage plan, it's almost always like 1 to 2 weeks, and I'm talking about like you had a hip fracture and you need therapy and they're going to give you 1 to 2 weeks. Whereas a counterpart who had a traditional Medicare plan might get 30, 60 days, up to 100 days of coverage. Probably have time for at least 1 or 2 more questions.
Isn't that 100 days a year?
It's actually the 100 days it'll start over if you've had a 60-day break from a hospitalization or a skilled nursing stay. So the day count will refresh after a 60-day break in that.
It's not a lifetime.
Correct. Yeah.
But you have to have a new event.
A new event. Yeah.
We have time to discuss reserve days, Medicare reserve days.
Jeff asked a question about Medicare reserve days.
You know, we used up all your, a lot of Medicare days, there's a certain number of reserve days, before you run out of Medicare coverage on regular Medicare. Is that not true?
I'm not sure.
30 or 60 then, reserve days.
Yeah, I don't know if that'll change.
Neither of us are as
I
familiar
know, I'm not
with
as
them.
familiar with that on what the reserve days.
It would be fair generalization to say that regular Medicare is for people that are maybe older, more ill, whereas the Advantage plan would be people relatively younger, costs are lower, you don't use the services. But like you said, it's harder to get services because you have to have prior referral. You have to use certain diagnostic places that are designated under your plan. Like you said, it's all private, it's not like a general Medicare.
Exactly. And what he's referring to is just kind of the generalization that Medicare Advantage, a lot of times when people are turning 65, they may be very healthy. And so you're sort of looking at, from a cost standpoint and a coverage standpoint, if you're 88 years old and you're on a Medigap Plan G or a Plan F, you're paying a lot of premium monthly for your coverage. So if I had someone the other day, she's 104, living at home, active, goes outside and picks weeds every day. If she had paid for a Medigap plan for all those years, I can't even imagine what the premium would be. So it's about the choice in care coverage and how you're choosing to pay. Medicare Advantage plans, I say, are more pay as you go, as you need them. We're gonna have years we need them more, and you may have a lot of years that you need them more, versus Medigap is going to give you more flexibility. You're gonna pay more for it on the front end, but you're sort of prepaying for down the road when you have those needs. And some people's, comfort level and cost restrictions are different than others. So and even affordability, I've got people that can afford either option and choose one just from a methodology of what they feel more comfortable with, if that helps a little bit.
Mhm. And there are some programs to help with the cost of premiums that Brooke can kind of talk to you about, and TN SHIP can also help you with that too. Was there one more question? Debbie?
With choices, you had said that what Choices pays is so much, and then the client pays the rest of the money. Do you have to pay all of their Social Security to the assisted living, like every dime?
Well,
Can you hold back a little bit for like their monthly expenses?
so the three different types of care that you can get under Group 1 and Group 2 are going to determine how much you have to contribute, right? If for Group 1 in the nursing facility, you get enough to pay your Medicare, you get $70 a month, the rest goes to the facility. It doesn't matter if you make $6,000 a month, it doesn't matter if you make $600 a month, that's the way it goes, right? If I'm married and I'm in the nursing facility, same thing, unless my spouse, their income is below like $2,400 a month, in which case I get to give enough money to them to gross them up to them. I get to keep $70 a month, enough to pay the Medicare, the rest goes to the facility, right? At home, I get to keep my income, actually unless it exceeds $2,900 a month, in which case I'm supposed to use whatever exceeds toward my care, right? Unless I'm married and we get the same thing where I get to give it back to the other spouse. Assisted living is the wild card, right? So if I'm on assisted living, they're going to contribute $1,400 a month toward the care. The actual rule says that they're not supposed to charge you more than $2,200 a month. Now, this is a real problem for individuals who only make $1,000 a month, because they've got to come up with $2,200 a month. If they go to the nursing facility, they only have to contribute their income, which costs the state $8,000 a month. But if they're in the assisted living, somebody else has got to come up with that extra $1,200. So the state's trying to move people to a place that costed $8,000 a month as opposed to a place that costed $1,400 a month. Sorry, I shouldn't have gone into that at the end, but it drives me nuts.
That's okay. We participate in Justice Knox in this church, so
okay.
we get on that soapbox with you.
It's just crazy. But anyway, so the rule is they have to contribute at least $2,200 plus any of their income that exceeds $2,900 is actually the way it's written. right? So if the person made $5,000 a month, they'd have to do $2,200 plus the amount. So they get to keep their own income between $2,200 and $2,900 is the way the rule's written. Now,
It's 1,300.
1,400.
1,400. Yeah, the state's gonna pay 1,400 regardless. Now, what I will say is what I should have started with, the way the actual assisted livings do this just varies. A lot of them will take their actual charge and just subtract 1,400 off the top. Some of them will say, yes, that's exactly how it works, but only if you have our smallest shared room with low cost, and then we'll add to it. Functionally speaking, I've never seen them charge a person over $3,000 a month, but I would say if you're in the assisted living and choices, it's ultimately gonna cost you between $2,200 and probably $2,800 a month. And if you're making $5,000, $6,000 a month, you can private pay for an assisted living without looking at choices anyway. So choices group, I would say overall, a lot more people get care in assisted living than at home or well, maybe more at home, but like more people get assisted living than they think because it's a really good price point for what you get. When it comes to choices, you see a lot more at home or in the nursing home and a lot less at assisted living because your income has to be almost perfect. You need to make between $2,200 and $3,000 a month for it to really be perfectly utilized.
And the other
Sorry,
thing that I
I'm-
wanted to say about that was some of the tools that Glenn talked about earlier, like setting up an irrevocable trust or doing that tool like a spousal annuity or the gift and annuity plan. Those tools are there because these programs are set up where they do not leave a lot of wiggle room. And so if you've done some planning and you have a trust, that trust can be used for those things like your other expenses like your clothing or a new pair of tennis shoes. $70 isn't a lot of money. And especially when we're looking at a person having a community spouse, we don't want to impoverish that well spouse. We want to make sure that that money's there later to pay for that person's care. So it's that balance.
That's good. Sorry, you asked the most complicated answer in this because there's not a one. I wish I could,
Assisted living is it's a little tougher when we're talking about group 2. One more question, guys.
I'll ask one.
Okay, Kim.
I need to move my dad from a place in Georgia to here, and he is a veteran, but will he go on Tennessee once he gets here?
That is such a good question for so many different people in this. That's like the perfect question for us to end. So first of all, let me kind of direct this. Brooke, you're in a different state. You're coming into the state of Tennessee. What do you do about your health insurance?
So depending on the coverage that he needs.
Well, he's on Medicaid.
Okay, so he would want to get on a Tennessee plan.
Okay.
Yes. He will need to get on a plan here because his plan is based on his zip code in the county that he's in. So we would want to get him switched to a plan in Tennessee.
Okay.
First off.
And if he's on Medicaid, what happens when you switch to a different state?
He's got to reapply in the state. And you have to, one of the things that we didn't talk about in there, you have to be a Tennessee resident, but you only have to be here for one day to have that. But you can't pre-apply. He's gonna have to move to a Tennessee facility first, and then you'll have to apply at that point.
Yeah. And if he is already on one of those programs like we talked about with choices for that other state, he probably will have an NCO care manager. So it's usually a social worker or a nurse within that state, within that managed care organization under Medicaid. You can contact that person and that person's going to help you. But also, likewise, if we're talking about these other programs, if you are already a claimant with a long-term care insurance and you move from home into assisted living, you need to notify them. So it's always about that sort of notification process. And Glenn has one more thought.
So number one, you need to make sure you get a nursing facility, if he's in a nursing facility care, that takes choices, right? Because if you don't, that's gonna be a problem. Second of all, I would go ahead and talk to them about how to pass that medical test. Tennessee is more restrictive than other states. I've had people that moved here from Indiana and Pennsylvania that were on long-term Medicaid for years in other states. We brought here and they turned them down because they said that they were too healthy. So be real careful on having somebody either at the facility look at the medical records and make sure they've got the charting to pass. And sometimes you're gonna have to pay for 1 month private pay where they can get the charting together to get that done. So just be careful with that. That's the trap.
I mean, his account is like down to nothing.
Yeah, the finances is gonna be the problem. It's gonna be the medical and the medical charting, because you've gotta pass all three,
Okay,
right?
okay. And do you, recommend a place like Ben Ashley is really hard to get into?
It is hard to get into. I mean, it's the best place you can go, but that's back to Gabe's side, so I'll let you talk to social.
Ben Ashley is very difficult to do a lateral transfer to. Usually Ben Ashley gives preference to people who are in a hospital setting going into the nursing home that way. I would recommend you contact business office. I'm sure Rachel can give you Sherry's number over at Island Home. I love that sweet little nursing home, and they do a really good job of looking at those and considering them.
Okay,
It's not gonna be the first time they've had someone transfer out of state.
Okay.
Okay, guys, we have covered a lot. Hopefully, this has given you a better understanding about some options for you. I think a lot of times people, what did you say?
Now for the test.
And now for the test. No one's gonna have a test. No one's gonna have a test. A lot of times people think they either pay out of pocket or just grin and bear it at home. And really what we want you to see is there's more options out there. We have a wonderful parish health team here. Val, raise your hand. Thank you, Val, for all you have done to make this. Jean and I voted, and you really have to lead this every single year forever and ever and ever. Right, Jean? We voted that. So we have a great parish health team here, and what they do is they are a team of people who have a medical background, and they can give you some guidance. So a lot of the questions you've asked here, we can direct those to Parish Health, and they can help you to find those answers, those tools and resources. We also have a wonderful Stephen Ministry program where we have people in the church who can walk alongside you as you're going through different challenges. And even though I am not technically a member of either of those teams, because I'm still an actively working social worker, and I still want to stay an actively working social worker, I am also a resource for you and can give you some general information and help to guide you. So do not do this alone, folks. Thank you so much for your time today.